Psychoanalytic Training Program. Module 5. Psychosexual Stages, From Childhood to the Superego. A complete digital audiobook training program by the Mercurius Foundation. This audiobook has been carefully crafted for your listening experience. We encourage you to pause, rewind, and revisit the passages that speak to you most. Topics in Sexuality. The study of sexuality for the psychoanalyst is a fundamental matter in several respects. First and foremost is the importance attributed by Freud to sexuality as the origin not only of all neuroses, but also of virtually all human behavior. Furthermore, in psychoanalytic practice, although at the beginning of treatment complaints directly related to sexuality rarely emerge, they will invariably appear in the course of the analytic process, provided that there is good rapport and a therapist's willingness to address such issues naturally. Unfortunately, sexuality is surrounded by a wide range of prejudices and distortions due to diverse historical, social, and cultural reasons, and health professionals, including psychiatrists, psychologists, and psychoanalysts, are not immune to these influences. The best example of this is Freud himself, who, with his decisive influence on the shaping and transformation of the psychological concepts of humanity, at times contributed to the dissemination of entirely erroneous notions that still have their adherents today. One such example is the idea that there are two types of female orgasm, vaginal and clitoral, with the latter being considered an immature orgasm and therefore undesirable. In this module, therefore, we will seek to present the main concepts, updated in accordance with current knowledge, regarding sexuality from a multidisciplinary perspective. This will include historical, social, anthropological, biological, and psychological aspects, as well as the conceptualization of sexual disorders as currently classified by the World Health Organization and the American Psychiatric Association. We will also address some issues related to gender identity and sexual orientation, without, however, intending to exhaust such a vast and comprehensive subject, so ordinary and yet, at the same time, so mysterious and, in a certain sense, still unknown. History of Sexuality. If we were to speak of the history of sex, we would have to begin with the first beings to reproduce sexually, that is, with distinct individuals exchanging genetic material, so that reproduction could involve greater variability of those very genes. Or perhaps with the first beings that began to have morphologically, and physiologically as well, distinct individuals, initiating the concepts of male and female. However, we are speaking of sexuality, which encompasses not only biological aspects but also the many cultural, social, and psychological dimensions that cannot be dissociated from its study. The history of sexuality, then, becomes restricted to the history of humanity, from the emergence of primitive man, in a complex evolution of concepts and prejudices, knowledge and myths, conquests and repressions, dominations and liberations. Instead of detailing here every step of this journey, let us allow Professor Mabel Cavalcante, pioneer of sexology in Brazil, to recount this history in a more poetic way, in an article published in the inaugural issue of the Revista Brasileira de Sexualidade Humana. It seems to have been Goethe who stated that the history of a science is the science itself. According to this conception, when we trace the historical perspective of human sexuality, we are, in some way, investigating human sexual conduct from a scientific standpoint. Since it is not possible to synthesize so many centuries in so little time, let us place greater emphasis on the sexuality of prehistoric man and that of certain ancient peoples. It is interesting to note that, on this journey, we have the opportunity to clarify many of today's questions about sexuality, for they have, in some form, already been asked or answered by our ancestors. It is not easy today to outline the life of prehistoric man, and we can only accomplish this to some extent through archaeological remains and ethnographic studies. Archaeological data give us an idea of the technology and customs of those peoples, and through ethnographic resources we can compare the artifacts found in prehistoric sites with those still used by primitive groups inhabiting our planet today. In the earliest times of humanity, the guidelines of human behavior were dictated by gods and demons. This was what is called the magical religious stage. Religion and magic have always been twin sisters. Through religion, man reveres the supernatural, or all that he does not know. Through magic, he attempts to manipulate this unknown. This anthro-sociological vision of the history of humanity allows us to understand human sexuality far more than if we looked only at the simple biological evolution of man as an individual. By studying sociocultural changes through the centuries, it is possible to see how man managed to satisfy his basic desires, especially those of hunger and sex. These studies also have the great advantage of showing us that there are numerous cultural variations among different societies, and that within each of these groups, sexual conduct and preferences varied from one individual to another. It is in successive cultural cycles that we can situate and discover the genesis of today's sexual behaviors. The sexuality we experience is nothing more than what humanity has made of it, or what it was compelled to make of it, in the face of environmental contingencies. To situate ourselves better, let us, in a synthetic way, try to focus on sexuality in terms of reproduction, pleasure, and love throughout the centuries. With regard to reproduction, although the subject is shrouded in much obscurity, all evidence suggests that in the earliest phases man did not associate sex with pregnancy. Gestation was considered a magical event, a gift from the gods, as much as the fertility of the earth. Perhaps for this reason, in tribes that were beginning agricultural activity, the task of sowing was performed by women. We know that even today, among certain primitive peoples such as the natives of Australia, the idea of sex and reproduction is not well developed. Among the Arunta, for example, there is the belief that child spirits inhabit certain totems, and that, under certain conditions, they can enter the body of women. Even more intriguing is the belief of the ancient inhabitants of New Guinea, who thought there was total independence between sexual intercourse and pregnancy. They claimed that women first gestated in the heart, with love, and only afterwards the fetus moved to the womb. The lyricism of this conception also reveals the dimension and value attributed to women in these primitive cultures. By contrast, man, in the most primitive stages of our evolution, sought women merely to calm his sexual tensions. In this pursuit, violence was generally the rule, and the position of coitus was the same as that of other primates, in a flagrant identification with the animal kingdom. It is not surprising, therefore, that at this time the erotic value of the buttocks as an attraction was at its peak. When we have the chance to observe the statuettes of prehistoric Venuses, we see the clear emphasis on highlighting the hips, buttocks, breasts, and belly. There is disregard for the head, the face, and even the shoulders. This can be observed clearly with the Venus of Lesbuk, among others. Of all of them, however, the most obese is the so-called Venus of Willendorf, found in Austria. The monstrous proportions of her forms surpass all modern surrealist standards. Yet, as the concept of beauty is highly relative, perhaps she was a kind of Paleolithic prototype of the girl from Ipanema. Some claim that the accentuation of forms, especially that of the breasts, is related to the cult of fertility. It seems, however, that it was erotic concern that inspired these prehistoric artists, both in the making of statuettes and in the cave paintings found inside caverns. In fact, many of them would make even the most skilled bathroom painters of today envious. A fact supporting the erotic inspiration of our earliest ancestors. A fact that corroborates the erotic inspiration of our most distant ancestors is the very characteristic of the economic life of these primitive populations. Living from hunting, fishing, and fruit gathering, they were obliged to move frequently from one region to another. It is evident that these individuals were not very concerned with exalting motherhood, since a numerous offspring would certainly have hindered the constant migrations of their nomadic life. There are also very convincing anthropological data showing that, at this time, infanticide was a common practice of population control. It must be understood that man was merely a predator of nature, and any threat of overpopulation posed a danger to the tribe. There was, therefore, no reason to exalt motherhood and procreation. This exaltation took place some 7 million years later, with the beginning of the so-called agricultural revolution, when man settled on the land and sought to draw sustenance from it. It must be clarified that the agricultural revolution, that is, the shift from nomadic to sedentary life, did not occur simultaneously in all tribes. Some remained at the stage of hunting, while others settled in valleys along rivers to live off the land as farmers. The activity of herding still, in some sense, implied displacements in search of better pastures, but tribes, as they domesticated livestock, horses and goats, began to settle in specific regions. Agriculture, however, was what determined the need to create much closer bonds with the land. The farmer is essentially a sedentary being, bound to the soil, as attached to it as the roots of the plants he cultivates. By assuming the role of farmer, offspring came to be considered of great importance. Man began to be concerned both with the fertility of the soil and with the fecundity of his women. Children, especially males, were important for the defense of territory and the cultivation of the land. From this time date the so-called fertility cults, and woman, as much as the earth, came to be venerated for her procreative capacity. Goddesses of fertility proliferated. Each tribe invented its own deities, attributing wisdom and omnipotence to them, and then bowing before their own creation, worshipping it. Nor did it stop there. To expand the domains of their beliefs, they conquered other tribes, subjugating them and imposing their creeds and divinities. In this stage of prehistoric life, religion universalized culture. In the rites, which abounded in offerings, dances, and songs, sacrifices held a prominent place. Since death was closely linked to the loss of blood, blood became associated with life. Hence the sacrifices involving the immolation of animals and humans, with blood flowing abundantly over the altars. This is probably the most remote origin of myths about menstruation. The menstruating woman lost life, something magical and inexplicable, hence the fears and taboos surrounding catamenia. A whole mythical conception was formed around this central fact. Menstruation was something they could not explain, and so it came to be avoided, people fleeing from it as something dangerous and impure. Even today, the taboo of impurity endures among Orthodox Jews and is still widely found, in a mitigated or disguised form, throughout Western civilization. The importance of blood in religion and magic is so great that, among the primitive inhabitants of Australia, in the ritual of male puberty, a bloody act, a small cut near the scrotum, granted boys the same right that was given to pubescent girls. Yet, man was still not regarded as a fundamental element in the reproductive process. Reproduction was the exclusive prerogative of woman, and practically all deities were female. With the passage of time, little by little, awareness of man's role in reproduction grew. It suffices to observe that among the Buka, a primitive tribe of the Solomon Islands, although they were unaware of the creative power of semen, they believed it was essential for a woman to become pregnant that the man introduced the penis into the vagina. It was as if the penis, through its movements, sanctioned the pregnancy. Tannehill reports that it was the observation of animal mating and the duration of gestation from coitus that led man to begin perceiving his enormous reproductive potential. After all, if a single ram could impregnate more than 50 ewes, what could a single man not do? There begin the seeds of sexist machismo. In the organization of religious life, alongside the goddesses of fertility, male gods began to appear. Worship of the vulva and worship of the penis. But this balance was very short-lived. The primitive scheme was soon reversed. The phallus came to symbolize strength, fertility, the talisman against sterility. In creation rites, the penis appears in clear or symbolic form, represented by fish or serpent, but always with a preponderant role. The serpent, probably because of its shape, was widely venerated as a phallic symbol. In Greek times, it was common to find live serpents alongside naked priestesses. At the Oracle of Delphi, the cult of Python, the sacred serpent, became famous. In excavations in Babylon, India, China, Sudan, Palestine, France, Corsica, Mexico, and Argentina, vestiges of this cult have been found. It is said that in Alexandria there was a procession with a gigantic phallus, about 120 cubits long. Stone monuments with phalluses ranging from 1.80 to 3 meters in height are frequently found on the island of Corsica. However, of all the licit representations, the most notable are the two statues of enormous penises, each 60 meters high, which stood guard at the Temple of Venus in Hierapolis. Beneath them was clearly visible the inscription, "I consecrated these phalluses to Hera, my mother-in-law." The reason for this tribute remains unexplained to this day, but the fact is that people would climb to the top of these penises to pray, fast, and offer sacrifices. The deification of the phallus. The deification of the phallus can be exemplified by the veneration of Priapus, who is depicted with an enormous erect penis. In Greek mythology, Priapus symbolized abundance and fertility, which explains why farmers and shepherds held him in such high esteem. Among the Romans, amulets in the shape of a penis were common, and even a winged penis was placed at the entrance of houses, inscribed with the phrase, "Hic habitat felicitas," here dwells happiness. The phallic cult was not observed only among the Greeks and Romans. We also find it among the Hindus, the Japanese, and even some African tribes. In France itself, it is said that near the village of Guéret there was a cult of Saint Grelicon. The saint was represented as a friar with an erect penis hidden beneath the ecclesiastical robe. Even today, we still suffer the influence of these beliefs. One example is the phallic language of the hands, where the raised middle finger represents the penis, while the bent index and ring fingers stand in for the testicles. The figa, made by placing the thumb between the middle and index fingers, is another penile symbol. For some peoples, it is more than this. It is an invitation to copulation. In certain rural regions of Europe, making the figa is a tremendous insult. Elsewhere, it is a discreet form of flirtation. In Brazil, the figa assumes a mystical and protective connotation, bringing luck to its bearer and defending them against all evils. It is interesting to note that it is not only the qualitative aspect that marks the phallic cult throughout history. The dimensions of the penis are also of importance, and this quantitative concern has reached such an extent that men have been judged by the size of their penis. The larger the penis, the more manly the individual was considered. In some way, this myth has survived into our own times, tormenting those with smaller penises. A more advanced stage in ideas of sex and reproduction is that in which phallic importance diminishes and woman comes to be considered more than a mere receptacle for fetal development. She gains the status of collaborator in the process of creation. It is interesting to observe how this collaboration was conceived. As always, there was a tendency for different myths to converge. Among the Wogios of New Guinea, it was believed that children were born from the mixture of menstrual blood with semen. Numerous superstitions proliferated along these same lines. Even the great Aristotle, De Generatione Animalium, affirmed that woman contributed to gestation with menstrual blood. For Hippocrates and Galen, the contribution consisted of vaginal secretions. Customs varied from people to people, but one always finds the idea of sex linked to the reproductive function. Among the Bororo Indians, there was a belief that children were generated through multiple copulations with several men. Thus, sexual relations with different partners were considered desirable. By contrast, the Man Indians of Guatemala claimed that a woman who copulated 2 or 3 times with her husband and did not conceive was an adulteress. For them, relations with more than one man prevented conception. Even more fantastic is the belief of the Cubio Indians, who prohibited sexual intercourse with a woman during pregnancy. They said that if the woman continued to copulate, she could accumulate such a number of fetuses in her abdomen that she would eventually explode. Although it is fascinating to study the relationship between sexuality and reproduction, it is important to value the stages in which primitive man began to view sex more in terms of pleasure than procreation. When in biological evolution, man assumed an upright posture, and above all, when face-to-face copulation became widespread, concepts of beauty began to change. The attraction of the buttocks was replaced by the beauty of the face, giving rise to the refinement of cosmetics, intended for facial beautification. At the same time, breasts also became highly valorized as erogenous regions. Peoples gradually shifted their focus from buttocks to breasts. Of course, this fixation did not always follow a necessary order of specific refinement. In Brazil, for example, buttocks are still far more admired than breasts. The idea of sex linked to pleasure is well defined by the Greeks. They called eros carnal love, quite distinct from pure, spiritualized love, which they named agape. Both were also distinct from philos, which indicated affection and friendship. It is characteristic of Greek thought to establish in man a dichotomous nature. The human being is defined as a rational animal. Rational because endowed with reason and spiritual values, animal because possessed of a body full of physical needs for survival. It is in this sense that one must understand the conceptualization of eros and agape. Eros is pure biology. It lacks the humanization that characterizes the human person. It is the affinity of bodies and, as such, contains sensuality and sexuality. Its imperative is selfish. I want is its keynote. There is an entire commitment to pleasure and possession, but there is not necessarily any bond of permanence. For this reason, Eros desires constant variation in its eternal search for pleasure. The Greek dual spirit extended to the constitution of the family, where the roles of wives and hetairai were clearly distinguished. Wives were for household management, procreation, and raising children, but not for sexual satisfaction. Under these conditions, it is not surprising that they sought in homosexual relationships, or through the use of dildos, artificially made penises often shared by many ladies, the pleasure denied them by their husbands. Sex and pleasure in antiquity. Sex and pleasure were destined for the hetairai. Some of them became famous in antiquity. Thais, the beautiful mistress of Alexander the Great, Aspasia, the intelligent companion of Pericles, not to mention Phryne, Philomena, Rhodopis, Glycera, and so many others who subdued, through pleasure, men who ruled empires and wrote the history of our Western civilization. The difference between eros and agape is so significant that the same individual could possess two loves, each with a different object: to love one partner sexually and another spiritually. Rising from the ruins of Greco-Roman civilization, Christianity continued to admit that sex was part of man's animal component. For many centuries, the Church regarded sexual love as an inferior form of love, tolerated only for the purpose of procreation. This was because the Christian moral code was based on the notion of nature, holding that an act is good when it accords with the purposes of nature and bad when it does not. Thus, hunger and sex balance out in terms of permanence. Hunger preserves the individual, sex preserves the species. Even today, this concept persists in the most conservative circles, which maintain that the true love that ennobles man is spiritual love, a kind of higher, sexless love, worthy of the rational condition of humankind. It is interesting how this establishes a paradox. Sexual love, considered inferior, gives rise to spiritual love, considered superior. For without sex there would be no individual, and without the individual there would be no human spiritual love. It is noteworthy that, from the moral point of view, these two conceptions have alternated throughout history, at times indulgent and tolerant, at times repressive and tyrannical. Using sin and shame as forms of control, the morality of sexual behavior has governed peoples throughout their existence. We must free ourselves from the Greek dualism and cease to regard sexual love as either superior or inferior to spiritual love. In human nature itself, the rational and the animal are intimately united, and so too must be sexual and spiritual love. Moreover, if we wish to make a correct assessment of what is normal and abnormal in human behavior, we must recognize that the concept of normality is not always tied to that of biological nature. Normal are also the codes of conduct adopted by the community, not only those behaviors aimed at fulfilling purely biological needs. Without underestimating the organismic variables, it is necessary to add cultural components to human nature. From this perspective, it becomes possible to understand variations such as fellatio, cunnilingus, masturbation, contraception, which naturally repulse orthodox moralists who, bound to the restrictive concept of nature, consider such acts unnatural. From all this, one lesson remains. Sex simply as a form of pleasure, or simply as a form of reproduction, gives an incomplete view of sexuality and does not satisfy humankind. It is both things and more still. It is, above all, a form of communication. Eric Berne states that humanity took a great leap forward when it separated the pleasures of sex from its merely biological reproductive purpose. Man is the only life form on this planet capable of making such an arrangement, arrangements that can lead him to a more solid plane. Breaking the barriers of his psychophysical isolation, man can extend himself into his partner as a mystical form of primordial communion. This mystical sense is observed in Eastern religions. Sex is loving communication, and since it is an activity for two, feedback of information is necessary, which further amplifies erotic stimulation. Sex is fun, pleasure, ecstasy. It is the total sum of eros and agape. By living the fullness of sexuality, giving and receiving love, we will be able to plan reproduction in an atmosphere of respect and mutual decisions. Only in this way will the exercise of sexual behavior reach its most creative, most pleasurable, most intimate, and most perfect form of human communication. Snake man, octopus woman. It belongs to the biological and chromosomal nature of man and woman to have distinct behaviors. Hormones are fundamental in this process, since testosterone impels man to seek females and spread his genes across the world. Woman, to attract the male, must have wide hips to accommodate pregnancy well. Yet nature has given human beings the instinct of self-preservation, and first they satisfy their own needs and desires before perpetuating the species. Sex first, fatherhood/motherhood later. The differences are perceived in various realms: biological, psychological, social, economic, cultural, spiritual. In personality, not only between male and female genders, but also in gender identity, gender roles, and sexual orientation. Despite all chromosomal determinism, the sexual life of human beings has one fundamental difference from that of other species: the how we are that gives us rationality, intelligence, creativity, and unique motivations that transform the simple biological ritual of sexual instinct into a love story. Unique, true, spiritualized, cultural. Love is built upon differences. Our daily affection. This only occurs because we possess a set of feelings that we call emotional behavior, which is the way of giving and receiving affection. Affection is a set of psychic phenomena that manifest in the form of emotions, passions, and feelings, always accompanied by the impression of pain or pleasure, satisfaction or dissatisfaction, liking or disliking, joy or sadness. Our daily affection must be considered in its simplest form of attention, which can be either positive or negative. Positive affection enables the other to experience continuous growth, mobilizing essential factors in the construction of self-esteem. Edina Bom Sucesso points to some elements she considers important for the building of self-esteem: self-acceptance, admitting our limits and recognizing those of others. Respect, adequately expressing emotions, knowing how to listen, maintaining confidentiality, apologizing. Supporting initiatives, assertive conduct, self-discipline. Friendships, in addition to genuine compliments. We co-live in society surrounded by people of the most diverse types and behaviors, sometimes so different from ours that they could make coexistence difficult. However, if we were exactly alike, things would not necessarily be easier. I bet you know that couple of friends whom you cannot understand how they are still together, since they argue all the time. All of us may even be able to live without sexual relations, but no one survives without affection. For this, some attitudes benefit us and our partner as well, contributing to a coexistence that is as coherent as possible. Love, dialogue, compliments, bodily touch, communion, assertiveness, spirituality, fantasies, complicity, and eroticism are key points in the unfolding of a healthy and promising relationship. Many of the difficulties couples face in their relationships, and even in bed, are closely related to one of these aspects, if not to all of them. Eroticism. Studies show that there is a difference between the male and female perspectives on eroticism. Male perspective centers the exercise of sexuality on erection. Partial vision. Instant interest disappears after ejaculation. Pleasure begins with the sight of the erect penis. Greatest stimulus is vision. Emphasizes genitality. Orgasm is orgasm. Orgasm is quantitative. Female perspective. Desires to be considered, admired, and caressed as a whole. Total vision. Continuous desire remains after orgasm. Affection, emotion, tenderness, sincerity, and sweetness stimulate eroticism. Greatest stimulus comes from touch and scent. Sexuality is a primary evidence. Orgasm is evaluated in relation to before and after. Orgasm is qualitative. These ambiguous positions often generate insecurities. This mismatch occurs precisely due to misinformation and difficulties in dialogue between the sexes. What matters is to capture the virtues of the masculine and the feminine, regardless of whether one is a man or a woman, integrating qualities and abilities by employing all positive affection. Sexual anatomy and physiology. The psychoanalyst does not necessarily need to know sexual anatomy in detail. It is up to the physician to diagnose and treat problems related to anatomical or biological disorders of the organs involved in sexuality. Here we will only make a brief review of the anatomy of the genital organs so that we can understand their physiology and the disorders that may occur in sexual function. The phases of human sexual response. The study of human sexual functioning from a physiological perspective was only initiated scientifically in 1954, with the research of William Masters and Virginia Johnson, whose results were first published in 1966 in the book Human Sexual Response. Until then, sex had been studied only from the standpoint of reproduction, leaving sexuality to sociological and psychological studies. Without a biological foundation, many psychological and sociological theories and concepts ended up exaggerating in their interpretations, losing much of their validity. One need only recall Freud's concepts regarding female sexuality, which are today considered invalid and, in some respects, absurd. Masters and Johnson divided the sexual response into 4 phases, known as the EPUR model of sexual response. These are excitement, plateau, orgasm, and resolution. Such phases were present in both men and women, although some differences were observed. Basically, men generally had a faster phase of excitement and a resolution phase that included a refractory period, immediately after orgasm, during which further arousal was impossible. Women, on the other hand, could follow variable patterns of arousal, from a rapid phase similar to men followed by plateau, to a slower arousal that could reach orgasm without passing through plateau. Moreover, women lacked a refractory period, making multiple orgasms possible. Helen Singer Kaplan, during the 1970s, modified this division, downplaying the importance of the plateau phase and disregarding the resolution phase, considering them clinically insignificant. Initially addressing the sexual response as biphasic, comprising excitement, which encompassed Masters and Johnson's E and P phases, and orgasm, their O phase. Kaplan soon realized that another stage was fundamentally important to the sexual response cycle, the phase of desire. After several years of working with sex therapy, Kaplan found that brief cognitive behavioral therapy techniques, which were applied to all patients, worked very well in cases such as anorgasmia, vaginismus, erectile dysfunction, and premature ejaculation. However, when there was a decrease in sexual desire, therapy tended to fail. In 1979, with the book Disorders of Sexual Desire, Kaplan established the triphasic model of sexual response, more suitable as a basis for diagnosing and treating sexual disorders. Thus, today we can schematize the human sexual response as follows. Stimulus, desire, excitement, orgasm. Each of these phases has its own physiology, whose detailed description lies beyond the scope of this lesson. It is enough to say that it involves psychological, neurological, and vascular mechanisms, the latter being responsible for the observable phenomena of arousal, that is, erection in men and vaginal lubrication in women. However, any attempt at simplification would give a false impression of the true complexity of the neurophysiology of sexual response. It is important to highlight, however, one single point that has been the subject of controversy and also criticism of psychoanalysis. This concerns the issue of female orgasm, which Freud considered could originate from two types of stimulation, vaginal and clitoral. Moreover, Freud asserted that vaginal orgasm was the only correct one, considering clitoral orgasm immature. Physiologically, there is no difference between orgasm resulting from direct clitoral stimulation and that resulting from intercourse, since the movements of coitus stimulate, through the traction of the labia minora, at least indirectly, the clitoris. Furthermore, a certain percentage of women do not reach orgasm solely through penetration, requiring direct clitoral stimulation, whether by the partner or by themselves, and are not to be considered abnormal for this reason. By dividing the sexual response into phases, we can more adequately classify the various problems that may occur, in order to guide us toward the most appropriate treatment for each disorder. But it is not enough to classify them according to the compromised phase of response. For a good chance of therapeutic success, we must investigate the possible causes of the disorders presented. Among the causes of sexual disorders, we observe everything from organic causes, interfering at different levels of the sexual response, to deep psychological causes, involving disorders rooted in remote phases of the individual's psychic history, as well as less profound psychological causes, whether individual or of the couple, and even sociocultural and circumstantial factors. It is the role of the psychoanalyst to work in conjunction with other professionals, sexologist, physician, acting primarily on the deep psychological causes, but also assisting in the approach to more immediate psychological causes, always maintaining an open and non-prejudiced stance toward sexuality. Sexual dysfunctions. According to Kaplan's model, sexual disorders were classified into disorders of desire, arousal, and orgasm. Not fitting into these three categories are disorders characterized by pain during sexual intercourse, vaginismus, and dyspareunia. Also placed separately in the classification are dysfunctions caused by medical, organic, conditions and those induced by chemical substances, both illegal substances and medications used for therapeutic purposes. Paraphilias, also called sexual deviations, are likewise classified separately. Freud studied them still with a prejudiced perspective, though less aggressive than previous approaches, even giving them the label of perversions. Sexual desire disorder. Initially disregarded due to the view of Masters and Johnson, who considered the sexual response only from the arousal phase onward, complaints of decreased sexual desire are now among the most frequent in sexological practice. In the last 2 decades, a significant number of studies have addressed the issue of sexual desire, particularly due to the finding that certain organic conditions may negatively affect desire, such as altered hormone production and side effects of medications. Disorders of desire are subdivided into 3 categories: hypoactive sexual desire, sexual aversion, and hyperactive sexual desire. However, when considering a couple, there is always the possibility of an inadequacy regarding desire without the presence of a true disorder, since what is considered normal sexual desire varies widely. As an example, in a couple where one partner would like to have sexual relations once a week while the other would prefer twice a day, important relational problems may arise, even though both are within what is considered the normal range. The inclusion of a category for hyperactive sexual desire may seem strange, but it is justified by cases where there is a lack of control over sexual impulses, with impulsive sexual behavior, a high frequency of sexual relations or masturbation, several times a day, to the point of impairing professional or social functioning, damaging personal relationships, and causing personal suffering. Individuals with hyperactive sexual desire can be considered as people with a sex compulsion, recalling obsessive-compulsive disorder, but with characteristics clearly distinct from it. The official classifications of DSM-4 and ICD-10 have not yet accepted the inclusion of this category, but Kaplan, 1995, categorically asserts the need for its diagnosis. On the other side of the continuum of sexual desire are sexual aversions. These are characterized by extreme aversion to and persistent or recurrent avoidance of all, or almost all, genital sexual contact with a partner, causing marked distress or significant interpersonal difficulties. Aversions may be primary, i.e. lifelong, or acquired, i.e. beginning after a traumatic event or situation. They may also be generalized, independent of the partner, or situational, depending on a specific partner or situation. Hypoactive sexual desire may range from mild to severe and is characterized by persistently or recurrently deficient, or absent, sexual fantasies and desire. For its characterization, factors such as age and the personal life context of the client must be taken into account. It is important for its diagnosis that the disturbance causes significant distress or interpersonal difficulties, and like aversions, it may be primary or acquired, generalized or situational. Sexual desire has a complex neurological regulation, depending on many factors, some of which are still unknown to science. Nevertheless, we can divide the factors influencing it into 2 groups: sexual incitants and sexual suppressors. Within these 2 groups, we can cite physiological factors such as testosterone, tactile stimulation, and possible aphrodisiac substances as incitants of desire, and prolactin, medications with sexual side effects, and depression as suppressors of desire. Psychological factors such as an attractive partner, erotic stimulation, fantasies, and love act as incitants, while an unattractive partner, negative thoughts, anti-fantasies, stress, and negative emotions act as suppressors. By acting on these factors, whether physiological, modifying medications and correcting endocrine disorders, for example, or psychological, stimulating fantasies and the use of erotic material and resolving situational conflicts and negative emotions, for example, we can help the client increase sexual desire, with at least partially satisfactory results in most cases. In a significant percentage of people, however, only deeper psychotherapy, capable of modifying the most remote factors of desire dysfunction, such as Oedipal conflicts, erotic childhood experiences, and negative injunctions from parents, teachers, and priests, can truly transform their sexual life. This is where the psychoanalyst's role comes in. to work together with the sex therapist so that treatment outcomes may be maximized. It is essential for the psychoanalyst to be knowledgeable about the more immediate factors that can influence desire and that will be addressed by sex therapy, so as not to fall into the error of seeking only the deepest roots of a problem, while allowing the rotten branches and leaves to prevent the restoration of healthy sexuality. Psychosomatic Model of Dual Control of Human Sexual Motivation by Helen Singer Kaplan. Sexual incitants. Physiological. Testosterone. Genital physical stimulation. Aphrodisiacs. Psychological. Attractive partner. Erotic stimulation. Fantasies. Love. Courtship. Sexual suppressors. Hypothalamic and limbic sexual regulatory centers. Physiological. Hormonal disorders. Drugs with sexual side effects. Depression. Psychological inhibitors. Unattractive partner. Negative thoughts. Anti-fantasies. Negative emotions. Stress and anger. Sexual desire. Sexual desire. Sexual avoidance. Sexual arousal disorders. Sexual arousal disorders include erectile dysfunction in men and alterations in vaginal lubrication in women. The introduction of sildenafil Viagra into the market in 1998 led to a revolution in the treatment of erectile dysfunction, being considered a true watershed in modern sexology. Initially feared by sex therapists as a possible emptying of their clinics, Viagra proved not to be an enemy, but a powerful ally of therapists. Since the causes of erectile dysfunction, from the most superficial to the most profound, are not modified by the use of medication, its simple use does not resolve interpersonal conflicts nor restore sexual well-being, either for the man or, even less so, for the woman. Thus, therapy for erectile dysfunction continues to include various cognitive and behavioral techniques, and, in some cases, may also require deeper treatment, such as psychoanalysis. The diagnosis of erectile dysfunction must take into account not only psychological causes, but also organic ones, among which diabetes mellitus and arterial hypertension stand out, especially regarding the side effects of antihypertensive medications. Drug use, particularly alcohol, can also play a role in the genesis of erectile difficulties. However, the main generator of erectile dysfunction is anticipatory anxiety. Through a snowball mechanism, the individual who fails once, haunted by the myth of the infallible man, by fears related to homosexuality, and by so many other distorted concepts of our sexual culture, begins to observe himself excessively during sexual relations. The stress generated by this demand for perfection ends up making erection even more difficult. In women, on the other hand, aside from organic causes, difficulty with sexual arousal is more often related to deeper causes, including sexual myths, as well as factors linked to the couple's relationship, also referred to as didactic causes. Sexual arousal disorders in women are very difficult to diagnose, since sexual desire is more commonly impaired, which secondarily affects arousal. It is rare to find women with intact sexual desire, but difficulty with arousal that is not of organic origin. Orgasm disorders. Orgasm disorders include anorgasmia, which is the difficulty or impossibility of reaching orgasm, and premature ejaculation, which is the difficulty or impossibility of delaying ejaculation long enough to maintain a satisfactory sexual relationship. Male anorgasmia is referred to as delayed ejaculation and often has the connotation of difficulty ejaculating only during intercourse, without such difficulty occurring during masturbation. In general, orgasm disorders tend to have more superficial causes, even when they are primary, meaning that the individual has never experienced an orgasm or never achieved adequate ejaculatory control. Thus, cognitive behavioral treatment, using well-established techniques, yields excellent results in most cases, and the need for psychoanalytic therapy is rare. It is worth noting that female anorgasmia is strongly linked to myths and prejudices, with many women complaining of anorgasmia even though they normally reach orgasm, albeit only through clitoral stimulation, considering themselves inadequate due to outdated concepts. At other times, anorgasmia is specifically related to the absence of orgasm with a particular partner, being more a consequence of desire disorders than of a problem with orgasm per se. Sexual pain disorders. In a separate category are sexual disorders characterized by pain during intercourse, regardless of the sexual response cycle. These include vaginismus and dyspareunia. Dyspareunia is pain during intercourse in women or men. In the vast majority of cases, it is related to an organic problem. However, especially in women, there is always a psychological component involved, and pain may be exclusively psychogenic, resulting from the combination of excessive contraction of vaginal muscles and insufficient lubrication due to difficulty with arousal. At times, sexual desire may be hypoactive, or there may even be sexual aversion, whether consciously perceived or not. Among men, dyspareunia almost always has exclusively organic causes. Vaginismus is a defensive reflex of the pelvic floor musculature, leading to spasm of the perineal muscles that prevents vaginal penetration, making intercourse, and even gynecological examination, impossible or extremely difficult. Most women with vaginismus have normal desire, arousal, and orgasm, often enjoying non-coital sexual activities, but are unable to achieve vaginal penetration. Although the causes of vaginismus are almost always exclusively psychological, leading to a kind of penetration phobia, treatment rarely aims to address such causes except in terms of cognitive reinforcement. Sexual therapy for vaginismus is essentially behavioral, including progressive muscle relaxation and systematic desensitization. Results with this brief form of therapy range from 72% to 99% success, and thus psychoanalysis is not recommended for such cases. Only when vaginismus occurs alongside other disorders with deeper causes are patients referred to long-term psychotherapy. Paraphilias. Paraphilias are defined as sexual disorders characterized by specialized sexual fantasies, intense needs, and practices that are generally repetitive in nature and cause distress to the individual. In the DSM-4, the diagnostic criteria for paraphilia always include a period of at least 6 months of persistence and the presence of clinically significant distress or impairment in occupational or other important areas of functioning as a consequence. Thus, practices limited to the sexual relationship of one or more individuals are excluded from the diagnosis of paraphilia, as long as they do not interfere with other areas of life or cause suffering to oneself or others. Previously regarded as perversions, practices such as masturbation, sexual relations involving more than 2 people, and even sexual fantasies are now considered absolutely normal, provided they do not cause suffering or invade other areas of the individual's life. What is still considered abnormal is any practice that is exclusive, meaning it is the only form of sexual expression, thereby limiting the individual's ability to relate in a healthy way. The issue of sexual orientation, particularly homosexuality, addressed later, was once considered a paraphilia. Today, homosexuals are no longer deemed paraphilic, with the diagnosis of homosexuality having been removed from international disease classifications since the 1970s. Exhibitionism. In exhibitionism, there is the impulse or desire to expose the genitals to an unsuspecting or unprepared person. The individual becomes aroused by the anticipation of the exposure and masturbates to orgasm during or after the event. Virtually all cases involve men exposing themselves to women, with the observation of the victim's reaction, fear, surprise, aversion, serving to affirm masculinity, which relates back to the castration complex. Fetishism. Fetishism consists of concentrating sexual focus on objects closely associated with the human body, such as shoes, panties, stockings, gloves, etc. The sexual activity may be directed toward the object itself, for example, masturbation inside a shoe, or the object may be incorporated into the sexual act, as in the requirement that stockings with garters be worn. It is also almost exclusively male and was considered by Freud to result from the castration complex, with the fetish being symbolically associated with this fact. Frauderism. This term designates the practice of rubbing the penis against the buttocks or any part of the body of a fully clothed woman, usually in places of large crowds, especially crowded buses and trains. For its characterization, such an act must be performed without the victim's consent and may also involve, at times, the use of hands to fondle an unsuspecting victim. Pedophilia. Pedophilia is the recurrent and intense sexual impulse or arousal toward children up to 13 years of age. To be characterized as a pedophile, the individual must be at least 16 years old and at least 5 years older than the victim. Excluded from this diagnosis are individuals in late adolescence who maintain a continuous sexual relationship with a preadolescent of 12 or 13 years of age. The vast majority of cases involve genital fondling or oral sex, with genital or anal penetration being less frequent, except in cases of incest. Most victims who are physically touched, approximately 60%, are boys, whereas in 99% of cases without physical contact, such as in exhibitionism, the victims are girls. It is important to note that 50% of pedophiles consume alcohol excessively at the time of the incident, and 95% are heterosexual. Sexual sadism and masochism. Sadism and masochism are closely linked, not only because of their complementarity, but also due to the presence of sadistic fantasies in 30% of masochists. Sadism refers to fantasies, impulses, or sexual behaviors involving real, not simulated, acts in which the psychological or physical suffering of another is sexually arousing. Masochism, on the other hand, is characterized by fantasies, impulses, or sexual behaviors involving real, not simulated, acts of being humiliated, beaten, bound, or otherwise subjected to physical or psychological suffering, which is sexually arousing to the individual. To clinically characterize sadism or masochism, it is necessary that such fantasies, impulses, or behaviors cause significant distress or impair social, occupational, or other important areas of functioning. Thus, many couples who incorporate sadomasochistic practices into their sexual lives, provided these do not cause distress or functional impairment, are not considered paraphilic, even if such practices may appear shocking to many. Contrary to common belief, masochism is more frequent in men than in women. Freud attributed it to destructive fantasies of the individual directed against the self through a mechanism of introjection. Analysis often shows that childhood experiences led the individual to believe that pain is a prerequisite for sexual pleasure, sometimes through simultaneous contradictory messages of pleasure and displeasure. Sadism, in turn, is considered by psychoanalysis to be a defense against castration anxiety, as if sadists were doing to others what they fear might happen to them, or, in the case of women, what they believe has already happened. Moreover, the little understood death instinct, or death drive, is generally at the root of this distortion of sexual pleasure. Voyeurism. Voyeurism refers to fantasies or acts that involve seeking or observing people who are naked, undressing, or engaged in sexual activity. Naturally, such fantasies or acts are considered normal as long as they do not cause significant distress, impair social or professional functioning, or damage interpersonal relationships. More common among men, voyeurism usually begins in childhood or adolescence and involves observation without the knowledge of those being watched, though arousal often depends on some degree of risk of being discovered. Transvestic fetishism. This refers to fantasies, impulses, or sexual behaviors in heterosexual men that involve wearing women's clothing. Typically beginning in childhood or early adolescence, it may evolve over time into the desire to dress and live permanently as women, at which point it is classified as transvestic fetishism with gender dysphoria. Not every man with transvestic fetishism fits into the transvestite subculture. Some use women's clothing only in solitary situations, which may lead to feelings of guilt and depression. There are also sexually healthy men who have transvestic fantasies within a positive and healthy context, but who are often inhibited by their partners in this aspect of their sexuality due to myths and prejudices surrounding homosexuality. Necrophilia. Necrophilia is the obsession with obtaining sexual satisfaction from corpses. In most cases, bodies are found in morgues, but some necrophiles desecrate graves to obtain the corpses they desire. In certain cases, the individual commits murder first, only to then have sexual relations with the corpse, revealing the psychopathic nature of this deviation. It is not uncommon for a necrophile to marry and demand that his partner take cold sitz baths before intercourse, or require that she remain completely motionless throughout the sexual act. Zoophilia. The inclusion of animals, which can be trained for this purpose, in sexual acts is relatively common, though it is rare as an organized and persistent paraphilia. Often, especially in more isolated regions where sexual contact is restricted by rigid religious and social conventions, relations with animals are frequent among the young. Situations of personal isolation, whether forced or circumstantial, can also lead to zoophilic practices without necessarily indicating a sexual deviation. Urophilia. This is sexual pleasure associated with the desire to urinate on one's partner or to be urinated upon. It can also be associated with masturbatory techniques involving the insertion of foreign objects into the urethra in both men and women. Coprophilia and clismophilia. Coprophilia is sexual pleasure associated with the desire to defecate on one's partner, to be defecated upon, or to ingest feces, coprophagia. Clismophilia, on the other hand, is the use of enemas as part of sexual stimulation. Theoretically, both are linked to fixation at the anal stage of psychosexual development. Partialism. In partialism, the individual focuses exclusively on a specific part of the body, disregarding all others. Normally, oral contact with the genitals is associated with the phase of sexual arousal, but when an individual uses such activities as the only source of sexual pleasure and cannot or refuses to engage in intercourse, this may characterize a paraphilia. Oral contact with the external female genitals is called cunnilingus. Oral contact with the penis is termed fellatio, while oral contact with the anus is referred to as analingus. Telephone scatologia. Characterized by obscene phone calls, telephone scatologia involves tension and anticipation that begin before the act itself. A victim, generally a woman, who suspects nothing, and the verbal exposure of sexual fantasies and concerns, or the attempt to induce the victim to talk about her sexual activity. The call is usually accompanied by masturbation, which may continue even after the call is ended. Variations of telephone scatologia are increasingly common through specialized phone services or via the internet, which provides everything from chat rooms to the use of email, text messages, and explicit images and videos. It is the compulsive use of these services that characterizes a paraphilia. When not compulsive, this can be considered a healthy means of sexual expression, provided that it does not inflict suffering. Masturbation. Masturbation is common at all stages of life, from childhood through old age, and is considered a normal and healthy autoerotic activity. However, for various reasons, including religious dogma, masturbation was historically regarded as pathological, blamed for a range of supposed ills, from acne to neurasthenia, which Freud himself associated with excessive masturbation. Even today, some people avoid masturbation, feel guilty when engaging in it, or even develop severe neuroses related to fears and taboos surrounding autoeroticism. When masturbation is the only form of sexual activity, when it is practiced so frequently that it disrupts other aspects of life, or when it is consistently preferred over sexual contact with a partner, it may be considered an abnormality, in much the same way as the fantasies and other practices described earlier. However, in most cases, when masturbation is practiced in a healthy and pleasurable way, there is no reason for condemnation. In fact, it can be an excellent means of stimulating sexually cold or worn-out relationships. Gender identity and sexual orientation. While biological sex, male or female, has a well-defined anatomical and physiological determination, the concept of gender encompasses much broader aspects than mere biology and heredity. The concept of gender identity involves biological, cultural, historical, psychological, and even spiritual questions. After all, what does it mean to be a man, and what does it mean to be a woman? From birth, or even before it, with technological resources that allow us to know the sex of the fetus months before delivery, we are subjected to a set of elements that will shape our notion of gender and our identity as men or women. From the chosen name, to the colors of baby clothing, the toys we are given, the education we receive, and the differing attitudes of parents, teachers, relatives, and religious figures. Everything contributes to the formation of each person's personal notion of gender and what it means to be male or female. Unfortunately, many myths and prejudices are embedded and ingrained in this notion, making it very difficult to distinguish between what are genuine differences and what are socially, culturally, or historically imposed ones. Since the last century, beginning with the feminist struggle for equality and later through the LGBTQ+ movements, Western society has been slowly working to dismantle some of these myths and prejudices. This has inevitably generated discomfort, as it touches structures solidified over millennia, but has gradually led to recognition of the need for change, even among men, who are increasingly realizing that the stereotype of the macho male is less and less suited to contemporary society. Today, we live in a transitional phase with a proliferation of books, debates, heated discussions, magazine and newspaper advice columns. In short, a general buzz. This is healthy, as a cultural means for the development of a new consciousness of sexuality. Such a consciousness does not yet have a clear form or structure, but shows signs of being broader, more tolerant of differences, and more respectful of the personal space of others. Sexual orientation, hetero, homo, or bi. Unlike gender identity, which is the individual's sense of self as male or female, and what that means, sexual orientation refers to preference in relation to sexual attraction. Thus, we call a person who is primarily attracted to people of the same sex homosexual, while those whose attraction is primarily to people of the opposite sex are termed heterosexual. A bisexual person is one who experiences sexual attraction toward both sexes. Although Freud did not consider homosexuality a mental illness, he regarded it as a variation of sexual function, produced by a certain impairment in sexual development. He grouped it with other personality disorders, attempting to justify homosexuality as resulting from strong maternal fixation, lack of effective paternal care, inhibition of masculine development by parents, fixation or regression in the narcissistic stage of development, or failure in sibling rivalry in the case of male homosexuals. For female homosexuality, he attributed it to unresolved penis envy and unresolved Oedipal conflicts. Many other hypotheses have been formulated regarding the origin of homosexual orientation, ranging from psychodynamic explanations to biological and hereditary alterations. To this day, this question remains heavily debated, without a definitive conclusion. The only universally accepted guideline is the declassification of homosexuality as a pathology. It is considered a disorder only in cases of ego-dystonic homosexuality, that is, when same-sex attraction is not accepted by the individual, leading to significant distress. A phrase by David Hawkins summarizes the situation of homosexuality well. The presence of homosexuality does not seem to be a matter of choice. Its expression is a matter of choice. Perhaps the most likely conclusion for the future is that sexuality is extremely broad, not necessarily limited to attraction toward individuals of the opposite sex, but involving the capacity to relate to both sexes, in an exchange of affection and pleasure that may be positively oriented, regardless of the other's sex, just as it should be in relation to skin color, geographic origin, religion, etc. Thus, the sex of the future would tend toward bisexuality, or rather, sexual universalism. Gender identity disorders. Classified separately from sexual dysfunctions, gender identity disorders are characterized by persistent feelings of discomfort with one's own biological sex, or with the gender role associated with one's sex. It is worth distinguishing these two expressions. Gender identity is a psychological state that reflects the intimate sense of self as male or female. It refers to how the person feels inside as male or female. Gender role, on the other hand, refers to the external behavioral pattern that reflects the person's internal sense of gender identity. In summary, gender identity is how a person feels, male or female, while gender role is how that person presents to others as masculine or feminine. These concepts must not be confused with sex, which is strictly limited to anatomical and functional, biological, characteristics, nor with sexual orientation, which is the individual's erotic tendency, taking into account object choice, sexual attraction, and the person's fantasy life. In gender identity disorder, there is persistent and intense distress regarding the assigned sex, along with a desire or insistence on being of the other sex. Individuals feel literally imprisoned in a body of the opposite sex, reporting that they do not experience that body as their own. Often, they believe they were born with the wrong sex and are unable to feel comfortable with their own body, despite therapeutic attempts. The treatment of choice is sex reassignment surgery, which, however, requires a precise diagnosis. If such surgery were performed on a homosexual individual without gender identity disorder, it would result in permanent and irreversible discomfort. Freud's view on sexuality. The list of Freud's writings on sexuality is extensive, even if we select only those that deal more directly with the subject. To gain at least a partial sense of his views, let us look at the summary he himself made of his essays, though it is strongly recommended to read them in full. Summary of 3 essays on the theory of sexuality. The time has come to attempt a summary. We began with the aberrations of the sexual drive in regard to its object and aim, and we encountered the question of whether they stem from an innate disposition or are acquired as the result of life's influences. The answer came to us through psychoanalytic investigation of the conditions of the sexual drive in psychoneurotics, a large group of people who are not far removed from the healthy. Thus, we discovered that, in these individuals, the inclination toward all perversions is demonstrable as unconscious forces, revealing itself in the formation of symptoms. We can therefore say that neurosis is, in a sense, the negative of perversions. Faced with the widespread presence of perverse tendencies, now recognized, we were led to the view that the disposition for perversions is the universal original disposition of the human sexual drive, and that from this disposition, through organic modifications and psychic inhibitions during maturation, normal sexual behavior develops. We hope to be able to identify this original disposition in childhood. Among the forces that restrain the direction of the sexual drive, we emphasized shame, disgust, compassion, and the social constructs of morality and authority. Thus, we had to regard every fixed aberration of normal sexual life as a fragment of arrested development and infantilism. Although it was necessary to place in the foreground the importance of variations in the original disposition, we had to assume a cooperative, not antagonistic, relationship between them and the influences of life. Furthermore, since the original disposition is necessarily complex, it seemed to us that the sexual drive itself must be composed of diverse factors, which, in perversions, become disentangled into their components. Hence, perversions revealed themselves on one side as inhibitions of normal development, and on the other as dissociations of it. These two conceptions were united in the hypothesis that the adult sexual drive arises through the fusion of various childhood impulses into a unity, an aspiration with a single aim. We added to this the clarification of the predominance of perverse inclinations in psychoneurotics, insofar as we recognized them as the collateral filling of secondary channels when the main channel of the sexual current is blocked by repression. At this point, we turned to the examination of sexual life in childhood. It seemed regrettable that the existence of the sexual drive in childhood had been denied, and that the sexual manifestations often observed in children were described as exceptional. On the contrary, it seemed to us that the child brings into the world the seeds of sexual activity, and that, even while feeding, enjoys a sexual satisfaction that it then seeks to reproduce through the familiar activity of sucking. Nevertheless, the child's sexual activity does not develop in step with other functions, but, after a brief flourishing between ages 2 and 5, enters the so-called latency period. In this period, the production of sexual excitation is by no means suspended but continues, providing a supply of energy that is largely employed for purposes other than sexual ones. On the one hand, contributing sexual components to social feelings, and on the other, through relationships and reaction formation, building the later barriers against sexuality. Thus, in childhood, at the cost of a great part of perverse sexual impulses, and with the help of education, the forces destined to keep the sexual drive within certain limits were constructed. Another part of childhood sexual impulses escapes these uses and manages to express itself as sexual activity. We then verified that the child's sexual excitation arises from multiple sources. Satisfaction arises above all through appropriate sensory stimulation of the so-called erogenous zones. In principle, any point of the skin, any sense organ, indeed perhaps any organ, can function in this way, although certain erogenous zones stand out, whose excitation is assured, from the beginning, by specific organic arrangements. In addition, sexual excitation appears to arise as a byproduct of numerous processes occurring in the organism once they reach a certain intensity, especially from all the stronger emotional upheavals, even when of a painful nature. The excitations from all these sources are not yet united, each pursuing its own aim, which is merely the attainment of a certain pleasure. In childhood, therefore, the sexual drive is not centered and is at first objectless, in other words, autoerotic. Already during childhood, the erogenous zone of the genitals begins to assert itself, either because, like any other erogenous zone, it produces satisfaction through appropriate sensory stimulation, or because, in a way not entirely understood, when satisfaction arises from other sources, sexual excitation is simultaneously produced in particular relation to the genital zone. We must admit with regret that sufficient clarification has not yet been reached concerning the relations between sexual satisfaction and sexual excitation, nor between the activity of the genital zone and that of the other sources of sexuality. Through the study of neurotic disorders, we observe that it is possible to identify, in infantile sexual life from its very beginnings, the rudiments of an organization of the components of the drive. In an initial and very early phase, oral eroticism takes the foreground, A second of these pregenital organizations is characterized by the predominance of sadism and anal eroticism. Only in a third phase, developed in the child only up to the primacy of the phallus, does sexual life come to be determined by the contribution of the proper genital zones. We then had to record, as one of our most surprising discoveries, that this early efflorescence of infantile sexual life, from ages 2 to 5, also entails an object choice, with all the richness of the psychic achievements it implies. Thus, the corresponding phase, despite the lack of synthesis among the isolated drive components and the uncertainty of the sexual aim, must be regarded as an important precursor to the later definitive sexual organization. The bitemporal establishment of sexual development in humans. The bitemporal establishment of sexual development in humans, that is, its interruption by the latency period, seem to us deserving of special attention. It appears to be one of the conditions of man's aptitude for the development of a higher culture, but also of his tendency toward neurosis. To our knowledge, nothing analogous can be demonstrated among man's animal relatives. The origin of this human peculiarity should be sought in the proto-history of the species. We could not determine what degree of sexual activity in childhood could still be described as normal and non-harmful for later development. The character of these sexual manifestations revealed itself as predominantly masturbatory. Experience further allowed us to confirm that external influences of seduction can provoke premature ruptures of latency and even its suppression, and that, in this respect, the child's sexual drive indeed proves to be polymorphously perverse. We also confirmed that such premature sexual activity harms the educability of the child. Despite the gaps in our knowledge of infantile sexual life, it was necessary to attempt a study of the transformations that occur with the onset of puberty. We highlighted two of these as decisive: the subordination of all other sources of sexual excitation to the primacy of the genital zones and the process of object finding. Both are already prefigured in childhood. The first is accomplished by the mechanism of preliminary pleasure. Sexual acts once autonomous, connected with pleasure and excitation, are converted into preparatory acts for the new sexual aim, the discharge of sexual products, the achievement of which, accompanied by immense pleasure, brings sexual excitation to an end. In this respect, we had taken into account the differentiation of sexually dimorphic beings into male and female, and we discovered that, in becoming a woman, a new repression is required, one that suppresses part of infantile masculinity and prepares the woman for the exchange of the dominant genital zone. Finally, we discovered that object choice is guided by infantile traces renewed at puberty, namely the child's sexual inclination toward the parents and other caretakers, which, diverted from these individuals by the incest barrier erected in the meantime, is then oriented toward others resembling them. It should also be added, lastly, that during the transitional period of puberty, the processes of somatic and psychic development continue for some time without connection to one another, until the eruption of an intense psychic motion of love, leading to genital innervation, produces the unity of the love function required for normality. Factors that disturb development. Each step along this long developmental course can become a fixation point, and each joint in this complex structure may allow the dissociation of the sexual drive, as we have already discussed through various examples. It remains for us to provide an overview of the various internal and external factors that disturb development, and to indicate the place of the mechanism affected by their disturbance. Clearly, the factors mentioned in the same series may not have the same value, and we must be prepared to face difficulties in properly evaluating each one. Constitution and heredity. First of all, it is necessary to mention the innate diversity of sexual constitution, upon which probably rests the greatest weight. Understandably, however, this can only be inferred from its later manifestations, and even then not always with great certainty. We conceive of this diversity as a predominance of one or another of the multiple sources of sexual excitation, and we believe that such differences in dispositions must express themselves in some way in the final outcome, even if this remains within the boundaries of normality. Without doubt, it is also conceivable that variations in the original disposition exist which necessarily lead, without the aid of other factors, to the configuration of an abnormal sexual life. These could be described as degenerative and considered as the expression of hereditary deterioration. In this context, I have a remarkable fact to report. In more than half of the cases of hysteria, obsessional neurosis, etc., that I treated psychotherapeutically, I was able to demonstrate with certainty that the father had suffered from syphilis before marriage, whether in the form of tabes or progressive paralysis, or whether the Lütich disease was indicated in some other way through the anamnesis. I wish to emphasize expressly that the children who later became neurotic bore no physical signs of hereditary syphilis, so that it is precisely their abnormal sexual constitution that must be considered the ultimate offshoot of their syphilitic inheritance. Although I am far from asserting that the descent from syphilitic parents is the invariable or indispensable etiological condition of neuropathic constitution, I do not believe that the coincidence I observed is accidental or insignificant. The hereditary conditions of positive perverts are less well known, since they manage to evade investigation. Even so, there are good reasons to suppose that what applies to neuroses also applies to perversions. Indeed, it is not uncommon to find perversion and psychoneurosis in the same family, distributed in such a way between the sexes that the male members, or one of them, are positive perverts, while the female members, in keeping with their sex's tendency toward repression, are negative perverts, that is, hysterics. This is strong evidence of the essential relationship we have discovered between the two disorders. Further elaboration of sexual disorders. On the other hand, one cannot defend the view that the configuration of sexual life would be unequivocally determined merely by the establishment of the various components of sexual constitution. On the contrary, the process of determination continues, and other possibilities arise according to the vicissitudes experienced by the tributary currents of sexuality deriving from the various sources. It is obviously this further elaboration that decides the ultimate outcome, while what could be described as an identical constitution may lead to three different results. When all dispositions are maintained in their relative proportion, considered abnormal, and are reinforced with maturation, the outcome can only be a perverse sexual life. The analysis of these abnormal constitutional dispositions has not yet been adequately undertaken, but we already know of cases easily explained by such hypotheses. Some authors opine, for instance, that an entire series of fixational perversions would have as a necessary precondition an innate weakness of the sexual drive. Expressed in this form, such a claim seems to me unsustainable, but it gains meaning when one considers a constitutional weakness of a specific factor of the sexual drive, namely the genital zone, which later assumes the function of unifying all isolated sexual activities into a whole, with reproduction as its aim. When the genital zone is weak, this unification demanded at puberty is doomed to fail, and the strongest among the other components of sexuality imposes its practice as a perversion. Repression. A different outcome occurs when, in the course of development, some components that were excessively strong in the disposition undergo the process of repression, about which we must insist that it is not equivalent to suppression. In this case, the corresponding excitations continue to be produced as before, but they are prevented by a psychic obstacle from reaching their aim and are deflected along many other pathways, until they succeed in expressing themselves as symptoms. The result may approximate a normal sexual life, restricted in most cases, but complemented by psychoneurotic illness. These are precisely the cases that have become familiar to us through the psychoanalytic investigation of neurotics. The sexual life of these people begins like that of perverts, and a large part of their childhood is occupied by perverse sexual activity, which occasionally extends beyond maturity. Then, for internal reasons, generally before puberty, but sometimes even after it, a reversal occurs owing to repression, and from that point on, neurosis takes the place of perversion, without extinguishing the former impulses. This substitution of perversion by neurosis in the life of one and the same person, as well as the already mentioned distribution of perversion and neurosis among different members of the same family, is consistent with the conception that neurosis is the negative of perversion. Sublimation. The third outcome of abnormal constitutional disposition is made possible by the process of sublimation, in which the hyperintense excitations arising from the various sources of sexuality find discharge and employment in other fields, such that from a disposition in itself dangerous there results a not insignificant increase in psychic efficiency. Here we find one of the sources of artistic activity, and depending on whether such sublimation is more or less complete, the characterological analysis of highly gifted persons, especially those of artistic disposition, reveals a mixture, in varying proportions, of efficiency, perversion, and neurosis. A subvariety of sublimation may perhaps be suppression by means of reactive formation, which, as we have discovered, begins in the child's latency period and, in favorable cases, continues throughout life. What we call the character of a man is constructed, to a considerable extent, from the material of sexual excitations and consists of drives fixed since childhood, others obtained by sublimation, and constructions intended to restrain effectively perverse impulses recognized as unusable. Consequently, the universally perverse sexual disposition of childhood may be considered as the source of a series of our virtues, insofar as, through reactive formation, it stimulates their creation. Accidental experiences. Compared with sexual discharges, with waves of repression and sublimations, the internal conditions of the latter two processes being at first unknown to us, all other influences appear far less significant. Whoever includes repressions and sublimations within constitutional disposition and regards them as vital manifestations of it may rightly assert that the final shaping of sexual life results, above all, from innate constitution. Yet no one with any discernment will contest the fact that, within such cooperation of factors, there is also space for modifying influences arising from accidental experiences in childhood or later. It is not easy to evaluate the effectiveness of constitutional and accidental factors in their reciprocal relation. In theory, one is always inclined to overestimate the former. Therapeutic practice emphasizes the importance of the latter. But in no case should it be forgotten that there exists between the two a relation of cooperation, not of exclusion. The constitutional factor must await experiences to activate it, while the accidental factor must rely on constitution in order to take effect. In most cases, one can imagine what has been called a complementary series, in which the decreasing intensity of one factor is compensated by the increasing intensity of another. Yet there is no reason to deny the existence of extreme cases at either end of the series. It accords even better with psychoanalytic investigation to give a place of distinction, among accidental factors, to the experiences of early childhood. The single etiological series then decomposes into two, which may be called dispositional and definitive. In the first, constitution and accidental experiences of childhood interact in the same manner as, in the second, disposition and later traumatic experiences. All factors harmful to sexual development exert their effect by promoting a regression, a return to an earlier phase of development. Let us now continue our task of enumerating the factors we have verified as influential in sexual development, whether they represent effective forces or mere manifestations thereof. Prematurity. One such factor is spontaneous sexual precocity, demonstrable with certainty at least in the etiology of neuroses, although like other factors, it is not in itself a sufficient cause. It manifests itself in the interruption, shortening, or suppression of the infantile latency period, and becomes pathogenic by producing sexual manifestations that, owing to the incompleteness of inhibitions on the one hand and the underdevelopment of the genital system on the other, can only bear the character of perversions. Such perverse tendencies may then persist as such, or, once repression is established, be transformed into driving forces of neurotic symptoms. In any case, sexual precocity hinders the desirable later mastery of the sexual drive by higher psychic instances, and increases the compulsive character which, aside from this, the psychic substitutes of the drive claim for themselves. Sexual precocity often runs parallel with premature intellectual development and, as such, is found in the childhood history of the most eminent and capable individuals. Under such conditions, it does not appear to become as pathogenic as when it arises in isolation. Temporal factors. Similarly, other factors deserve consideration, which, alongside precocity, may be grouped under the designation of temporal. The order in which the various instinctual impulses are activated, as well as the span of time during which they may manifest before succumbing to the influence of a newly emergent impulse or to some typical repression, appear to be phylogenetically determined. Nevertheless, both in this temporal sequence and in this duration, variations seem to occur which must exert a decisive influence on the final outcome. It is not indifferent whether a given current emerges before or after its countercurrent, for the effect of a repression cannot be undone. Every temporal deviation in the arrangement of components invariably produces a modification in the result. On the other hand, impulses that emerge with special intensity often run an astonishingly rapid course, such as the heterosexual attachment of those who later become manifest homosexuals. There is no justification for the fear that tendencies most violently established in childhood will permanently dominate the adult character. It is equally to be expected that they may disappear, giving way to their opposite. We are not even in a position to provide indications of the causes of these temporal complications in the processes of development. Here opens before us a panorama of a dense phalanx of biological, and perhaps also historical, problems with which we are not yet sufficiently equipped to engage. Adhesiveness. The significance of all early sexual manifestations is heightened by a psychic factor of unknown origin, which for now can certainly only be presented as a provisional psychological hypothesis. I refer to the high adhesiveness or fixability of these impressions of sexual life, which must be admitted in order to account for the facts in persons who later become neurotic or perverse, since the same premature sexual manifestations in other individuals do not imprint themselves so deeply as to produce compulsive repetition and to prescribe, for an entire lifetime, the paths of the sexual drive. Part of the explanation of this adhesiveness may perhaps lie in another psychic factor which we cannot neglect in the causation of neuroses, namely, the preponderance which memory traces assume in psychic life in comparison with recent impressions. This factor is obviously dependent on intellectual development and increases in proportion to the elevation of personal culture. As a result of the inverse relation between culture and the free development of sexuality, a relation whose consequences can be closely traced in the shaping of our life. The importance of the course taken by the child's sexual life for later life is very slight at the lower cultural or social levels, and very great at the higher ones. Fixation. The The ground prepared by the psychic factors just mentioned is favorable to the accidentally experienced stimuli of infantile sexuality. The latter, above all, seduction by other children or by adults, furnish the material which, aided by the former, may become fixed as a permanent disturbance. A large part of the deviations from normal sexual life later observed both in neurotics and in perverts is established, from the very beginning, through impressions from the infantile period, supposedly devoid of sexuality. Their causation involves constitutional compliance, precocity, the characteristic of high adhesiveness, and the fortuitous stimulation of the sexual drive by external influences. Nevertheless, the unsatisfactory conclusion that emerges from these investigations into the disturbances of sexual life derives from our insufficient knowledge of the biological processes that constitute the essence of sexuality, so that from our isolated insights we cannot yet form a sufficient theory capable of encompassing both the normal and the pathological. Freud's writings on sexuality. It is clear that references to sexuality are found in the great majority of Freud's writings. The list below comprises those works that deal more directly with the subject. The date at the beginning of each item corresponds to the year of publication, and the Roman numeral in parentheses to the volume of the complete works in which it appears. 1898 3. Sexuality in the Etiology of the Neuroses. 1905 7. 3 Essays on the Theory of Sexuality. 1906 7. My Theses on the Role of Sexuality in the Etiology of the Neuroses. 1907 9. The Sexual Enlightenment of Children. 1908 9. Character and Anal Erotism. 1908 9. On the Sexual Theories of Children. 1908 9. Civilized Sexual Morality and Modern Nervous Illness. 1910 11. 5 Lectures on Psychoanalysis, Lecture 4. 1910 11. Leonardo da Vinci and a Memory of His Childhood, Chapter 3. 1910 11. A Special Type of Object Choice Made by Men, Contributions to the Psychology of Love I. 1912 12. Contributions to a Debate on Masturbation. 1913 12. The Disposition to Obsessional Neurosis, a Contribution to the Problem of the Choice of Neurosis. 1913 13. The Claims of Psychoanalysis to Scientific Interest, Part 2c. 1913 12. Preface to Scatologic Rights of All Nations by Burke. 1914 14. On Narcissism, an Introduction. 1916 to 1715. Introductory Lectures on Psychoanalysis, Lectures XX, XXI, XXII, and XXVI. 1917 17. Instincts and Their Vicissitudes, exemplified in Anal Erotism. 1918 11. The Taboo of Virginity. 1919 17. A Child is Being Beaten. 1920 18. The Psychogenesis of a Case of Homosexuality in a Woman. 1922 18. Some Neurotic Mechanisms in Jealousy, Paranoia, and Homosexuality, Section C. 1923 18. 2 Encyclopedia articles. 2 The Theory of Libido. 1923 19. The Infantile Genital Organization. 1924 19. The Economic Problem of Masochism. 1924 19. The Dissolution of the Oedipus Complex. 1925 19. Some Psychical Consequences of the Anatomical Distinction between the Sexes. 1927 XXI. Fetishism. 1931 XXI. Libidinal Types. 1931 XXI. Female Sexuality. 1933 XXI. New Introductory Lectures on Psychoanalysis, Lectures XXXI and 33. 1940 XEI. 1938. An Outline of Psychoanalysis, Chapters 3 and 7. 1940 XEI. 1938. The splitting of the ego in the process of defense. Infantile sexuality and psychoanalysis. In psychoanalytic theory and practice, sexuality does not designate only those activities and pleasures that depend on the functioning of the genital apparatus, but rather an entire series of excitations and activities present from childhood onward, which provide a pleasure irreducible to the satisfaction of a fundamental physiological need, breathing, hunger, excretion, etc., and which are found as components within what is called the normal form of sexual love. Psychoanalysis, as we know, assigns great importance to sexuality in the development and psychic life of the human being. But this thesis cannot be understood without at the same time taking into account the transformation undergone by the very notion of sexuality. The aim here is not to determine the role of sexuality in psychoanalytic conceptions of the human being, but rather to specify, with respect to scope and meaning, the use psychoanalysts make of the concept of sexuality. If we start from the common view that defines sexuality as an instinct, that is, as a preformed behavior, characteristic of the species, with a relatively fixed object, a partner of the opposite sex, and goal, union of the genital organs in coitus. One quickly perceives that this definition explains very imperfectly the facts supplied both by direct observation and by analysis. Extension of the concept. The existence and frequency of sexual perversions, catalogued by certain psychopathologists at the end of the 19th century, revealed a great variety in the choice of sexual object and in the modes of activity employed to obtain satisfaction. Freud established that there are numerous transitions between perverse sexuality and so-called normal sexuality. The appearance of temporary perversions when habitual satisfaction becomes impossible. The presence, in the form of activities that prepare and accompany coitus for pleasures, of behaviors otherwise found in perversions, whether as substitutes or as indispensable conditions for satisfaction. The psychoanalysis of neuroses demonstrates that symptoms represent realizations of sexual wishes, expressed in displaced forms, modified by compromises with defense. Often it is precisely perverse sexual wishes that we find behind one symptom or another. For Freud, however, it is above all the existence of infantile sexuality, active from the very beginning of life, that enlarges the field of what psychoanalysts call sexual. By speaking of infantile sexuality, one does not mean to recognize merely the presence of early genital excitations or needs, but also activities akin to adult perverse activities, insofar as they involve bodily zones, erogenous zones, that are not limited to the genitals, and insofar as they seek pleasure, thumb-sucking, for example. In this sense, psychoanalysts speak of oral sexuality, anal sexuality, and so forth. Defining the sexual. This broader extension of the field of sexuality necessarily led Freud to seek the criteria for what is specifically sexual in these various activities. Once it is established that the sexual is not reducible to the genital, just as the psychic is not reducible to the conscious, what authorizes the psychoanalyst to attribute a sexual character to processes where the genital is absent? This question arises above all in relation to infantile sexuality, since in the case of adult perversions, genital excitation is generally present. Freud addressed the problem directly, especially in lectures XX and XXI of the introductory lectures on psychoanalysis, 1915 to 1917, where he raises the following objection to himself. Why insist on already calling sexuality these manifestations of childhood that you yourselves are the first to acknowledge as indeterminate, and out of which the sexual will only later be constituted? Why not simply say, remaining content with physiological description, that already in the infant one observes activities, such as sucking and the retention of excrement, which show us that the child aims at organ pleasure? Although leaving the question unresolved, Freud answers by presenting a clinical argument. The analysis of adult symptoms leads us back to those infantile activities that generate pleasure, and this through material that is incontestably sexual. To posit that infantile activities themselves are sexual presupposes an additional step. For Freud, what is found at the end of a development that can be reconstructed step by step must have existed, at least in germ, from the very beginning. Yet, he ultimately acknowledges that we are not yet in possession of a universally recognized sign that would allow us to affirm with certainty the sexual nature of a process. Freud repeatedly declared that such a criterion should be discovered within the biochemical order. In psychoanalysis, all that can be asserted comes from clinical evidence, which shows us its evolution and transformations. Thus, Freud's reflection seems to stumble upon a double aporia. On the one hand, concerning the essence of sexuality, whose final word is left to a hypothetical biochemical definition. On the other, concerning its genesis, since Freud contents himself with postulating that sexuality exists virtually from the start. It is precisely with regard to infantile sexuality that this difficulty is most evident. Yet it is here, too, that we may find indications of a solution. Already at the level of near physiological description of infantile sexual behavior, Freud showed that the sexual drive differentiates itself out of the functioning of the great apparatuses that ensure the conservation of the organism. At first, this can only be referenced as a surplus of pleasure occurring alongside the execution of a function, pleasure from sucking, in addition to the satisfaction of hunger. At a second stage, this marginal pleasure is sought for its own sake, beyond any nutritional need, beyond functional pleasure, without external object and in a purely localized manner at the level of an erogenous zone. Support, erogenous zone, autoerotism are for Freud the three interlinked characteristics that define infantile sexuality. We can see that when Freud seeks to determine the moment of the emergence of the sexual drive, it appears almost as a perversion of instinct, in which the specific object and organic aim are lost. From a rather different temporal perspective, Freud repeatedly emphasized the notion of afterwardness. Nachtraglichkeit, new experiences confer on earlier, relatively indeterminate experiences a meaning they did not originally possess. One could then say that infantile experiences, thumb-sucking, for example, begin as non-sexual, and that their sexual character is only secondarily attributed once genital activity emerges. This conclusion seems to weaken, by underlining the retroactive element in the constitution of sexuality, what was stated earlier about its immediate emergence, and even more so, the genetic perspective according to which sexuality is already implicitly present from the start of psychobiological development. This is precisely one of the central difficulties of Freud's theory of sexuality. Insofar as sexuality is not a fully preformed apparatus, but rather establishes itself along the course of an individual history that shifts across bodily systems and aims, it cannot be understood solely on the plane of biological genesis. Yet conversely, the facts show that infantile sexuality is not a retroactive illusion. A possible solution lies in the notion of primal fantasies, or proto-fantasies, which in some way balances that of afterwardness. Freud referred to these, invoking a phylogenetic explanation, as certain fantasies, primal scene, castration, seduction, which are found in every subject and structure human sexuality. Sexuality, therefore, is not explicable solely through endogenous maturation of the drive. It is constituted within intersubjective structures that pre-exist its emergence in the individual. The fantasy of the primal scene may, in its content and bodily significations, correspond to a given libidinal phase, e.g. sadistic anal. But in its very structure, representation and solution to the enigma of conception, it is not explained by simple conjunctions of observational clues. It constitutes a variant of a schema that is already there for the subject. At another structural level, The same may be said of the Oedipus complex, defined as governing the triangular relation between child and parents. It is significant that the psychoanalysts most dedicated to describing the play of fantasies imminent to infantile sexuality, the Kleinian school, saw the Oedipal structure in action very early. Freud's reservation against a purely genetic and endogenous conception of sexuality is also confirmed by the importance he continued to assign to seduction, even once he acknowledged the existence of infantile sexuality. Infantile sexuality is thus doubly complex. Endogenous, insofar as it follows a line of development and passes through distinct phases. Exogenous, insofar as it breaks into the subject from the adult world. The child must immediately situate itself within the parent's fantasy universe and receives from them, openly or covertly, sexual incitements. For this reason, infantile sexuality resists simplistic reduction either to physiology or to an idealized account that would make it the mere disguise of love. When Freud encounters it in psychoanalysis, it is always in the form of desire, a desire that, unlike love, remains dependent on a determined bodily support and, unlike need, requires fulfillment under specific fantasy conditions, strictly governing object choice and the articulation of activity. Sexual disorders. An individual presenting with sexual disorders has not completed the normal developmental process toward healthy adult adjustment. The persistence of the unconscious infantile threat of castration by the father or separation from the mother leaves an open field for the development of such disorders. Attempts to associate organic factors with sexual behavior invariably result in generalizations that render the hypotheses flawed. Abnormal hormonal levels, mild or subclinical neurological signs, chromosomal abnormalities, and nonspecific changes on electroencephalogram may appear in some cases. In reality, the differentiation between normal and abnormal sexuality is extremely subtle and subject to multiple influences. Sexual behavior and personal fantasies are highly intimate matters and only rarely come to medical attention. We remain far from identifying clear psychological or organic factors that can be said to account for any specific behavior. Despite the consensus that disorders of sexual identity and sexual preference are not rare, and that their definitions are relatively straightforward to operationalize, epidemiological studies are scarce. This may be because diagnoses are often not made. Examiners frequently do not inquire about patients' sexual intimacies, because in most cases the symptoms are egosyntonic and therefore not presented as complaints, or because they are deliberately withheld. More than 50% of sexual preference disorders begin before the age of 18. Sexual identity disorders, on the other hand, rarely begin after the age of 21 and are often reported in children as young as 3 to 5 years old. Pedophilia is the most common sexual preference disorder. Approximately 15% of all children have been molested before reaching the age of 18. Violence against children is always taken with utmost seriousness, and discovered cases invariably reach the public domain. Cases of sadomasochism are consistently underrepresented, as only the most severe ones involving legal or police consequences are recorded. Among patients with sexual preference disorders who seek treatment, nearly 50% present with pedophilia, 25% complain of exhibitionism, and 12% of voyeurism. The 10th edition of the International Classification of Mental and Behavioral Disorders, ICD-10, of the World Health Organization, WHO, divides sexual disorders into 3 groups. Sexual dysfunction not caused by organic disorder or disease, F52. Sexual response is so intrinsic to personality that it becomes impossible to assess the relative importance of psychological versus organic factors. Some types of dysfunction, such as loss of sexual interest, affect both men and women, though women more frequently report lack of pleasure or interest. Lack or loss of sexual desire. This is the primary problem, not secondary to other difficulties such as erectile failure or dyspareunia. Although it does not eliminate the possibility of pleasure, it makes initiating sexual activity more difficult. It is classified as a hypoactive sexual desire disorder, often expressed as frigidity. Total. The individual never, at any time, experiences pleasure during intercourse. There is no libido. Partial. Desire occurs only occasionally. These women typically have great difficulty reaching orgasm. Situational. Desire dysfunction is linked to specific circumstances, such as an inadequate sexual partner, an inappropriate environment, love nest, or trauma associated with sexual activity, e.g., sexual violence, and persists as long as the problem remains. Sexual aversion and absence of sexual pleasure. The possibility of sexual intercourse provokes intense negative feelings, strong enough to lead the person to avoid sexual relations altogether. In some cases, sexual responses occur normally and orgasm can be achieved, but there is a lack of appropriate pleasure, referred to as sexual anhedonia. Lack of genital response. In men, characterized by erectile dysfunction occurring during intercourse, while erections may arise normally in other contexts such as masturbation, with a different partner, or during sleep. The fundamental factor is most likely psychological. In women, the most common problem is vaginal dryness or failure of lubrication. Relevant factors may be psychogenic, infections, or estrogen deficiencies, frequently occurring during menopause. Orgasmic dysfunction. Orgasm fails to occur or is markedly delayed. This condition may be situational, occurring primarily with certain partners, or invariable when physical factors cannot be excluded. It is more common in women than in men. Orgasmic dysfunctions, or anorgasmia, are classified as follows. Primary. The woman has never experienced orgasm. Secondary. The woman becomes anorgasmic after previously experiencing orgasm. Total anorgasmia, commonly known as frigidity, the complete inability of a woman to reach orgasm under any circumstances. Partial anorgasmia, difficulty in reaching orgasm, marked by a slow or diminished orgasmic response. Situational anorgasmia, difficulty in achieving orgasm in specific circumstances, similar to situational desire dysfunction described earlier. Additional factors include guilt. Many women, burdened by guilt associated with sexuality, find their thoughts diverted from the act itself. Narcissism. In some cases, women overly focused on their own beauty may be so preoccupied with maintaining their appearance, not disturbing hair, breaking a nail, etc., that they cannot concentrate on the sexual act. Premature ejaculation. Defined as the inability to control ejaculation sufficiently to allow both partners to achieve orgasm. In some instances, the woman's orgasm may occur even earlier than the man's. This condition typically manifests only during intercourse, whereas ejaculation may occur normally during masturbation. Types include organic. Causes include diabetes, neurological disorders affecting penile sensitivity, conditions leading to reduced androgen levels, among others. Psychological. The majority of cases, which may involve fixation on self-erection linked to adolescent masturbation, fixation on the phallic stage associated with urination, leading to unconscious fear of punishment for ejaculation, marital discord, or unconscious aversion to fatherhood. Non-organic vaginismus. Characterized by spasms of the vaginal musculature, leading to occlusion of the vaginal opening. Penetration becomes difficult, painful, or even impossible in pathologic vaginismus. Non-organic dyspareunia. Refers to pain during sexual intercourse, occurring in both men and women. This diagnosis should be used only when no other sexual dysfunction is present, such as vaginismus or vaginal dryness. Excessive sexual drive. Not commonly presented as a complaint, though it may occur in both men and women, particularly during adolescence and early adulthood. In men, it is referred to as satyriasis, and in women, nymphomania. When excessive sexual drive is secondary to a primary disorder, it should be coded accordingly. Sexual identity disorders. Although relatively rare, these disorders attract attention due to their striking, often bizarre, and frequently inappropriate characteristics. Transsexualism. Defined as the desire to live and be accepted as a member of the opposite sex. It is usually accompanied by a sense of discomfort or incongruence with one's own anatomical sex. Patients frequently seek hormonal treatments and surgeries in order to make their bodies congruent with their preferred sex. Dual-role transvestism. Characterized by wearing clothing of the opposite sex for a brief period in order to enjoy the temporary experience of being the opposite sex. There is no desire for sex reassignment, nor any pursuit of hormones or surgery. Gender identity disorder in childhood. A persistent and pervasive desire of a child to be of the opposite sex. It is accompanied by strong rejection of the behaviors, attributes, and/or clothing of the original sex. Generally begins in the preschool years. It occurs more often in boys than in girls. Approximately 70% of these individuals, when reaching adulthood, maintain a homosexual orientation. Disorders of sexual preference. These share certain characteristics: persistent, repetitive, or intrusive sexual fantasies. They are often egocentric, but recognized as unusual. Sexual arousal and orgasm are entirely dependent on these fantasies, which play a central role in the patient's life. In severe cases, other psychiatric diagnoses may be present, such as borderline personality disorder or psychoses. Fetishism. Characterized by dependency on certain inanimate objects, typically articles of clothing or footwear, as stimuli for sexual arousal and gratification. Fetishism should only be diagnosed when it constitutes the most important or sole source of sexual excitement. Fetishistic transvestism involves wearing clothes of the opposite sex to obtain sexual arousal. Fetishistic transvestism differs from transsexual transvestism by its association with sexual excitement, coupled with a strong desire to remove the clothing immediately after orgasm. Exhibitionism. A recurrent or persistent tendency to expose the genitals to strangers or to people in public places, without invitation or intention of pursuing further intimate contact. Sexual arousal occurs during the exposure, and the act is commonly followed by masturbation. Voyeurism. A recurrent or persistent behavior of watching people engaged in sexual or intimate behaviors, such as undressing, without their knowledge. This observation provokes sexual arousal and typically leads to masturbation. Pedophilia. Defined as sexual preference for children, usually of prepubertal or early pubertal age. Despite its relatively high frequency, pedophilia is rarely identified in women. Freud classified pedophilia as a perversion of weak and impotent individuals who are attracted to children because they are weaker and easier to dominate when other objects are barred by anxiety. Sadomasochism. A sexual preference involving activities of bondage, pain, or humiliation. When the individual prefers to be the object of such stimulation, it is called masochism. When the individual prefers to inflict it, it is called sadism. Many individuals exhibit both characteristics. Multiple disorders and other disorders. Necrophilia. A sexual disorder characterized by the need for sexual intercourse with corpses. It is linked to a mental disturbance often considered hereditary. It has a clear relation to the castration complex, where the equation may be defined as: to have intercourse with someone already dead does not bring the risk of castration. Disorders of this order carry a neurotic component, but also a deeply psychotic one, in which, during moments of anguish, There is dissociation from reality, and the instinct drives the individual intensely toward the need for sexual gratification with a dead body, one that cannot react. Zoophilia, also known as bestiality, it consists of sexual relations with animals. This disorder is most often found among perverted individuals with characteristics of roughness, insensitivity, and crudeness, more common in rural areas among farm workers. Due to neurotic disturbances, such individuals experience an affective blockage toward loving a human partner. On a conscious level, they maintain the mistaken belief that an animal is more suitable than a fellow human in sexual terms. Incest, characterized by sexual practice among persons united by family ties. It usually results from a displacement of object choice during the Oedipal developmental period, in which parental libido is redirected to a specific family member. Most frequent cases are between siblings, parents and children, or close relatives. Gerontophilia, defined as the sexual preference for elderly individuals. Many of these perverse tendencies develop in those who were raised by elderly people, sometimes their own parents, during the early stages of psychosexual development. Through interference at these stages, regression occurs, and fixation at that point defines the individual's sexuality. Treatments. In general, sexual disorders are associated with an unfavorable prognosis. However, some factors may improve prognosis, such as motivation for change. Factors that worsen prognosis include early onset, high frequency of acts, absence of guilt or shame, and the associated use of drugs. The individual's motivation to seek treatment is the determining factor for achieving favorable outcomes. Treatment must consider all biological, psychological, and social factors involved in sexuality. Many of these disorders are rooted in underlying medical problems, which must also be treated. Frequently, medication-related factors, both medical and psychiatric, are involved. It is important to note that even in masturbation, which allows pleasure through one's own body, the sexual drive is dominantly directed toward a relationship with another person, whether real or imagined. This interpersonal dimension gives sexual life its peculiar character. In long-term couples, sexual satisfaction is a crucial factor in maintaining harmony. Successful, pleasurable. Sexual relations give partners a sense of mutual gratitude that helps them endure everyday tensions. Dissatisfaction, on the other hand, intensifies small antagonisms. For this reason, encouraging good communication between partners is essential. Such communication requires open dialogue on all aspects of sexuality. Adulthood does not guarantee freedom in sexual life. Prejudiced attitudes still weigh heavily, preventing partners from speaking openly about desires, preferences, and limits. The foundation of such dialogue must be the recognition that the ideal lover does not exist. Sexual life is an ongoing process of discovery, in which partners learn more about one another over time. Men often struggle to accept women's initiative, partly because they themselves are not always willing for sexual engagement. Women, although physiologically less restricted, may sometimes force themselves into a disposition that is not psychologically present. These aspects are rarely discussed openly between partners. Many men still judge themselves as sexually insufficient due to perceiving their penis as small. In nearly all cases, such inadequacy is not anatomical but psychological. Men are biologically limited in terms of repeated orgasms, whereas women, with greater anatomical and physiological freedom, can experience multiple orgasms and even sustain sexual relations while feigning desire. Only by accepting these limits can frank and open dialogue occur. Sexual life is a constant learning process, in which each partner must listen to the other's desires. This is not easy. Deviations such as pedophilia, fetishism, necrophilia, and rape illustrate the difficulty of respecting the partner and the frequent tendency to annul them. It is also essential to consider biological limits. Numerous medical conditions underlie erectile dysfunction, including cardiovascular diseases, aortic aneurysm, heart failure. Urological disorders, Peyronie's disease, hydrocele, varicocele, genetic conditions, Klinefelter's syndrome, and endocrine disorders, diabetes mellitus. Treating such conditions is crucial to avoid their impact on erection and ejaculation. Side effects of various substances, such as tricyclic antidepressants, imipramine, clomipramine, etc., lithium carbonate, and amphetamines, can also impair erection, ejaculation, and orgasm. Other abused substances, such as alcohol, cocaine, and heroin, may further compromise erectile and ejaculatory function. Antidepressants including imipramine, clomipramine, nortriptyline, fluoxetine, and sertraline can inhibit female orgasm. Whenever symptoms appear alongside these medications, cost-benefit analysis of treatment is required. Although difficult, treatment should always be multidisciplinary, involving medical professionals, psychiatrist, gynecologist, endocrinologist, psychologists of various orientations, and social workers. Reports of psychoanalytic, behavioral, and directive techniques exist in the treatment of sexual disorders, but no method proves universally effective. This reality demands a humble openness to alternative forms of investigation. Psychoanalysis and psychoanalytically oriented psychotherapies are the most common approaches to these problems, despite the scarcity of controlled studies. They help patients understand the psychological dynamics of events and attempt to reformulate them. Behavioral therapy should be employed to correct specific patterns of sexual maladjustment. Unpleasant aversive stimuli are paired with impulses, which then tend to decrease. Cognitive techniques, self-awareness, self-assessment, and self-affirmation, and systematic desensitization can also be applied. Medication use is restricted to symptoms or associated anxious or depressive syndromes. Medication should be prescribed for limited periods and with very precise indications, serving only as an adjunct to psychotherapy. Theories of psychosexual development. Until the end of the last century, sex was conceived as an instinct that awakened at puberty and aimed at reproduction. Sexuality was understood exclusively in terms of adult genital sexuality. Childhood sexuality was denied or regarded as an anomaly. At the beginning of the 20th century, Freud's revolutionary postulations located sexuality in childhood and in the unconscious, broadening the concept of the term sexual, which ceased to be synonymous with genital. This expanded view was presented in 3 essays on the theory of sexuality, 1905. In it, the term sexual appears linked to a set of activities not restricted to the genital organs, beginning in childhood rather than puberty, and whose purpose is pleasure, not only reproduction. These postulations naturally sparked numerous debates, gradually shaping a new view of human sexuality, one that began to be seen with less prejudice. The concept of sexual normality tends to be considered as anything practiced by legally competent adults, with the partner's consent, and without physical harm to any participant. Sexual excitement is essentially characterized by penile erection in men and vaginal lubrication in women, triggered by stimulating activities or thoughts. Plateau, the stage of heightened sexual arousal and tension that immediately precedes orgasm. Erection, in men, completed by vasoconstriction of the penile corpora cavernosa, increasing size and diameter. In women, by nipple and clitoral erection. These changes are accompanied by sensations of pleasure. Orgasm. In men, ejaculation occurs with contractions of the spermatic cord, seminal vesicles, prostate, and urethra. In women, with vaginal and uterine contractions. Resolution. A gradual decline of erection, with the penis and clitoris returning to their habitual size due to loss of vasocongestion. partners experience relaxation and well-being. During this stage, men become refractory to new orgasms for a period that lengthens with age, whereas women can experience further orgasms almost immediately. Freud reconstructed, through patient treatments, pediatric observations, and descriptions of psychopathological cases and primitive peoples, the various stages an individual passes through from birth. He elaborated the theory of the progression of libido, from the oral stage to the anal and then to the genital stage, with the consequent sequential reorganization of the drive and the nature of the ID. Erikson, 1976, proposed that the individual moves from trust to autonomy and to activity through the sequential reorganization of the ego and character structures. Spitz, 1979, referred to the organizing principles that lead to successive restructurings of ego precursors. Mahler, 1993, concluded that the individual evolves from normal autism to normal symbiosis and then to separation individuation, a notion later abandoned due to contradictory empirical observations. Ego and ID are restructured, but in terms of the baby's experience of self and other. Klein, 1974, described the schizoid paranoid and depressive positions, which lead to restructuring of the experience of self and other. Stern, 1992, considered his approach closer to the latter two, as his central concern is with the infant's self and other experience. However, he differed regarding the nature of this experience. He emphasized the developmental sequencing of the sense of self, free from the confusions brought by issues of ego or ID development. Shared psychoanalytic premises. All psychoanalytic theories share a central premise. Development progresses from one stage to the next, with each stage not only being specific to the development of the ego or the ID, but also to certain protoclinical issues. Developmental stages are linked to specific clinical questions that later unfold as pathologies in subsequent stages of life. Yet, as Stern highlights, Peter Freud and Klein criticize this view, arguing that it is a retrospective theory of development, one that reconstructs the past from more evolved structures and translates it through the morphology of pathology. Phases of sexual development, psychosexual phases. Freud was the first to provide us with a clear picture of the great importance that the relationship with other people has for our psychic and sexual life and development. The first of these is, naturally, the child's relationship with the parents. This relationship is, at first, in most cases, mainly restricted to the mother or her substitute. A little later comes the relationship with siblings, other close companions, and the father. Freud pointed out that the people to whom the child becomes attached in his early years occupy a central position in his psychic life, one that is singular in terms of its influence. This is true whether the child's attachment to these people is through bonds of love, of hate, or both, the latter case being the most common. In the early stages of life, the child does not perceive objects as such and only gradually, over the course of the first months of his development, learns to distinguish his own person from objects. Among the most important objects of childhood are also included the various parts of the child's own body, that is, his fingers, toes, and mouth. All of them are important as a source of gratification, which is why we admit that they are highly cathected by the libido. To be more precise, we should say that the psychic representatives of these parts of the child's body are highly cathected, projection of an emotional energy onto a given object. Since we no longer believe that libido is like a hormone that can be transmitted to any part of the body and fixed there. Freud called this state of self-directed libido narcissism, after the Greek legend of the youth Narcissus, who fell in love with himself. The child's first objects are called partial objects. By this we mean, for example, that only after a long time does the mother exist for the child as a total object. Before that, her breast or the bottle, her hand, her face. Each of these consisted, in the child's mental life, of separate objects. And it may very well be that even different aspects of what physically constitutes a single object are also, for the child, distinct objects, not united or related. A continuous object relationship only develops in the latter part of the first year of life. One of the important characteristics of these early object relations is their high degree of what we call ambivalence. That is, feelings of love may alternate with equal intensity with feelings of hate, depending on circumstances. The earliest phases of object relations are commonly designated as pregenital object relations, or sometimes more specifically as oral or anal object relations. The habitual use of the word pregenital in this sense is incorrect. The proper term would be prephallic. In any case, in psychoanalytic literature, the child's object relations are commonly referred to according to the erogenous zone that, at the moment, is playing the most important role in the child's libidinal life. The characteristics of infantile sexuality, polymorphous and perverse, Freud described well in 3 essays on the theory of sexuality. Infantile sexuality differs from that of the adult in several aspects. The most striking difference lies in the fact that the greatest excitation is not necessarily located in the genitals, but in the fact that the genitals, properly speaking, play the role of primus inter pares among many erogenous zones. The aims also differ. They do not necessarily lead to sexual contact, but extend into activities that will later play a role in forepleasure. Infantile sexuality can be autoerotic, that is, taking its own body or parts of it as its object. The components that are directed toward objects bear archaic traits, aims of incorporation, ambivalence. When a partial instinct is blocked, collateral partial instincts are correspondingly reinforced. The small child is an instinctual creature, full of polymorphous perverse sexual impulses, full of a total, still undifferentiated sexuality, which contains in one all the partial instincts. Freud suggested that 2 types of excitation can be distinguished. One that is evoked by external, perceptual, discontinuous stimuli. The other that results from continuous instinctual stimuli within the organism. The assertion must, however, be considered in more detail. All perception, all sensory stimuli, whether originating outside or within the organism, have a provocative character. That is, they provoke a certain impulse to action. The exceptional role that the displacement of energy gives to sexual instincts was the point from which Freud started in his first classification of instincts, since he noted that neurotics felt unwell because they had repressed certain experiences, and because these experiences always represented sexual desires. The forces that fought against sexual desires were anxiety, feelings of guilt, the ethical and aesthetic ideals of the personality. These countersexual forces could be summarized as the instincts of the ego, seeking self-preservation. A structural conflict arises in which the ego rejects certain demands of the ID, and, based on the concept of the ego as a differentiated superficial layer of the ID, one can no longer sustain the hope that the ego innately harbors other instincts not present in the ID. Even though instinctual energies are treated in the ego differently than they are in the ID, it must be admitted that the ego derives its energy from the ID, not containing, initially, other types of instincts. Although the phases are distinctly described, it is a mistake to imagine that they occur absolutely isolated, for they may overlap, occur in parallel, or coincide, and they will never be completely overcome, as is observed in adulthood, in behaviors that prove the existence of the phases of infantile sexuality, which in most cases occur in neuroses. One can generally divide pre-adult sexuality into 3 main periods: the infantile period, the latency period, and puberty. Today, the beginning and the end of the infantile period are well known, whereas that which lies in the middle still requires much research. Possibly in this intermediate period occur accidental variations more important than those that take place in the initial and final phases. Pregenital, prephallic, or infantile period. Freud designates it as pregenital because the genital zones have not yet reached their predominant role. At birth, the human being carries unconscious impulses in search of pleasure. The natural impulses of the ID are manifestations of an innate tendency, whose cause is the libido or sexual energy. Oral phase. It is the oral state, more correctly intestinal, of the organization of the libido. The child, in the fetal stage, has already developed the instinct of sucking. The baby, right after birth, finds pleasure in sucking the mother's breast and in the emptiness he feels when he removes his mouth from it. His enjoyment is unconscious, clinging to the mother's breast with satisfaction, looking into the mother's eyes during this moment, with the nutritional factor established as a secondary desire. The child sucks everything he finds, fingers, pencils, merely for the pleasure of sucking. Freud showed that when sucking produces pleasure, it is combined with the friction of certain parts of the body, such as the ear, navel, or external genitals, these acts being characterized as the precursor movement that leads the child to practice masturbation. The autoerotic phenomenon of thumb sucking shows that the pleasure obtained from the breast or the bottle is not based solely on the gratification of hunger, but also on the stimulation of the erogenous oral mucosa. If it were not so, the infant would remove the thumb, disappointed, since it produces no milk. Here, sexual excitation was originally supported by the need for food. Likewise, the first sexual excitation also leaned on other physiological functions: breathing and cutaneous sensations, sensations of defecating and urinating. Many phenomena stemming from this phase are retained in the adult, such as kissing and many eating habits. Oral introjection is, at the same time, the executor of primary identification. The ideas of eating an object or of being eaten by it become the modes by which one unconsciously thinks of any object relation. The magical communion that consists of becoming the same substance, whether by eating the same food or mixing respective bloods, as well as the magical belief that we become similar to the object we eat, are based on this same fact. Some manifestations of oral neuroses are excessive drinking and eating, language and speech problems, aggression with words, corresponding to biting, insults, mockery, exaggerated scruples not to bother, unconscious desire to settle and displace all people, inability to accept favors and receive gifts. The eagerness for knowledge, the study of languages, singing, oratory, and recitation are examples of sublimation of oral tendencies. Anal phase. The analysis of obsessive neuroses allowed Freud to insert, between the oral and phallic periods, another organizational level of the libido, namely, the sadistic anal level. Although anal pleasure is present from the beginning of life, it is in the second year that the anal erogenous zone seems to become the main executive of all excitation, which then, wherever it originates, tends to discharge through defecation. It is the phase in which the libido is concentrated in the anal region, which becomes an area charged with pleasant emotion, with first the physical satisfaction of the emptiness felt after the exit of feces, the emptying of the intestine, and then the mental satisfaction the child feels in performing this function for its parents. This region comprises the junction of the skin and the anorectal mucous membrane. The junctions of skin and mucous membranes of the body are sensitive and, when receiving gentle stimulation, produce feelings of pleasure. The primary aim of anal erotism is certainly the enjoyment of pleasurable sensations in excretion. Stimulation of the rectal mucosa can increase with anal retention, while exemplifying the combinations of erogenous pleasure and security against anxiety. The fear of originally pleasurable excretion leads to retention and to the discovery of the pleasure this latter produces. The possibility of carrying out more intense stimulation of the mucosa, beyond the more intense sensation due to increased tension of retention, is responsible for tensional pleasure, which is greater in anal erotism than in any other. Those who, in their satisfactions, seek to prolong pre-pleasure and extend final pleasure are always latently anal erotics. The refusal of a child to defecate is a way of defying parental authority and reaffirming that the feces belong to them, finding additional pleasure in the sensation of keeping the rectum full. They consider feces as an integral part of themselves, with which they present their parents and the surrounding adults, being very precious, since it is given from within their own body, from their being. The handling of feces by the child stems from this phase, being disapproved of by parents as something disgusting, dirty. Despite this undesired value transmitted by parents to children consciously, to the unconscious goes a message of repression due to the value attributed to feces by the child. Where anal fixation, anal neurosis, has occurred, even if feces themselves cannot be indefinitely accumulated, the individual will accumulate whatever of value they can acquire, hoarding, without however reaching its appropriate use. Let us look at some cases of anal neurosis. The miser who hoards money. The collector who buys valuable paintings and neither exhibits them nor even looks at them. Obsessive individuals who insist for a long time and unproductively on unfinished tasks. Exaggerated punctuality. Tendency to use dirty underwear. Thirst for power. Pleasure in the discharge of foul language. Children who were forced to defecate by orders, when adults, present a marked tendency to have their problems solved by others and tend to perform various activities simultaneously, which manifests itself in an obsession with reading during defecation. The origin and nature of the connection that exists between anal and sadistic impulses, alluded to in the expression used to designate the level of organization, anal sadism, are analogous to orality and sadism. Partly they are due to frustrating influences, and in another part, to the character of the aims of incorporation. Two factors are added. First, the fact that elimination is objectively as destructive as incorporation. The object of the first anal sadistic act is the feces themselves, whose expulsion is perceived as a kind of sadistic act. Later, people are treated as feces once were. Secondly, the factor of social power involved in sphincter control. In exercising cleanliness, the child finds an effective opportunity to express opposition against adults. There are physiological reasons for the connection of anal erotism on one side and on the other, ambivalence and bisexuality. Anal erotism makes the child treat an object such as feces in a contradictory manner. It expels the matter from the body and retains it as if it were a loved object. There lies the physiological root of anal ambivalence. On the other hand, the rectum is a hollow excretory organ. Excretory, being able to actively expel something. Hollow, being able to be stimulated by a foreign body that penetrates it. The masculine tendencies derive from the first faculty, the feminine from the second. There we have the physiological root of the connection between anal erotism and bisexuality. When the child has premature personal hygiene training, the individual later, as an adult, may have hostile and rebellious behavior. However, in its formal aspect, he presents as clean, obedient, passive, and fearful. When the child has late hygiene training, the individual will tend to be unclean, careless, and irresponsible. When hygiene education is at the proper time, the individual will unconsciously have a normal sense of power and consciously an appropriate attitude toward dirt and cleanliness. As sublimation of anal phase tendencies, that is, the deviations of the drives toward culturally accepted aims, we have activities of the plastic arts, which are more ostensive transformations of the infantile pleasure of playing with feces. Urethral eroticism. The appearance of infantile urethral eroticism is closely linked to infantile genital eroticism, about which little can be said before discussing infantile genitality. It is frequent, however, that it appears in later states as a pregenital opponent of genuine infantile sexuality. The urethral erotic child necessarily perceives the difference between the sexes with reference to urination, for it is common for urethral eroticism to appear combined with the castration complex. Although the primary aim of urethral eroticism is certainly the pleasure of urination, there is also a secondary pleasure of urethral retention, analogous to the pleasure of anal retention, and there are conflicts developing around this. This is seen most frequently in girls, probably for anatomical reasons. In any case, it does not seem justified to adopt the idea suggested by Ferenczi of making the pleasure of retention synonymous with anal pleasure and excretory pleasure synonymous with urethral pleasure. The original aims of urethral eroticism are autoerotic, just as those of anal eroticism are. Later, too, urethral eroticism can turn toward objects, the urethral apparatus then becoming the executive of sexually exciting fantasies related to the act of urinating on objects, of being urinated upon by objects, or fantasies in which the connection with urination is less evident. It is common for the child to actively wet pants or the bed for autoerotic pleasure. Later, enuresis may develop as an involuntary neurotic symptom, whose nature is that of the unconscious equivalent of masturbation. In general, the pleasure of urinating has a double character. In both sexes, it can have phallic and even sadistic significance, urination equivalent to active penetration, with fantasies of injuring or destroying, or it can be felt as letting it flow, as passive surrender and relinquishment of control. The aim of passive flow can condense with other passive aims in boys. For example, being caressed on the penis, or being stimulated at its root or in the perineum, in the prostate. The active phallic part of urethral eroticism in boys is soon replaced by normal genitality. But it may happen that urethral erotic aims conflict with genitality, often condensed with anal aims. It is true that sometimes male urethral eroticism is associated with fantasies, indeed sadistic, as seen in the analysis of cases of severe premature ejaculation. Often the idea of letting it flow shifts from urine to tears. In women, later urethral erotic difficulties occur, most frequently expressing conflicts revolving around penis envy. There is a connection between urethral eroticism and the feeling of shame. Phallic phase. At the conclusion of infantile sexuality, the genital concentration of all sexual excitation is accomplished. Interest in the genitals and masturbation reaches dominant significance. A kind of genital orgasm even appears. This was the phase Freud called infantile genital organization, or phallic phase. It is the precursor phase of the final form assumed by sexual life and closely resembles it, occurring around the 4th year of life. In this phase, the child discovers pleasure in the genital region, whether by the contact of wind or the hand of the one who performs their hygiene, even unconsciously. Thus, boys begin to touch the penis more often and girls the clitoris, hence the term phallic. The ego of the 3- or 4-year-old child is more experienced, more developed, more integrated, and consequently different in many respects from the ego of the 1- or 2-year-old child. These differences are evident in the functioning of the ego, that is, in the characteristics of the child's object relations connected to the ego. At this age, if development has been normal, the child no longer has partial object relations. Thus, the various parts of the mother's body, her different moods, and her contradictory roles as good mother who satisfies the child's desires and bad mother who frustrates them, are all recognized by the child at this age as composing a single object called mother. There are no specific oral, anal, and genital libidos. There is only one libido, which displaces from one erogenous zone to another. In cases where certain fixations develop, forces operate that resist displacement of this order, so that, for example, the pregenital fixations of neurotics hinder the progressive genital concentration of excitation during the sexual act. Pleasure is basically found in these regions, where it will remain, although in girls there is a displacement, we could say partial, to the vagina and in puberty to the clitoral vaginal. No strong libidinal cathexis is ever completely abandoned. It is possible that a large part of the libido flows to other objects, but at least a certain amount remains attached to the object of origin. It is in this phase that children of both sexes awaken the desire to see each other's genitals, as well as to show their own, including in this act of curiosity and exhibitionism other parts of the body and also other bodily functions. Masturbation, the stimulation of one's own genitals for the attainment of sexual pleasure, is normal in childhood. Under current cultural conditions, it is also normal in adolescence and even in adulthood as a substitute when the sexual object is unavailable. If an individual whose sexual activities are blocked by external circumstances refuses to use this expedient, analysis always reveals unconscious fear or feelings of guilt at the root of the inhibition. Patients who did not masturbate in adolescence also reveal that their sexual desires were heavily crushed by fear and guilt, cases in which the prognosis is poor, generally resulting from especially deep repression of infantile masturbation. Urination is also a component of infantile sexuality, called urethral eroticism. The boy is then awakened to amuse himself in the sizing of the stream of urine, where lies the root of the future concern with strength, with competition, with power, with the desire to be greater, more powerful, and more important. The fact that adults threaten or joke about castration so easily and eagerly certainly constitutes the expression of their own castration complexes, because frightening others is a great way to calm one's own fears, resulting in castration complexes being passed from generation to generation. The castration anxiety in boys. The fear that something might happen to this sensitive and cherished organ is called castration anxiety, a fear to which such a significant role is attributed in the boy's overall development and which represents a result, not a cause, of this heightened narcissistic valuation. It is only the high narcissistic cathexis of the penis during this period that explains the efficacy of castration anxiety. Its precursors in oral and anal anxieties, through the loss of the breast or of the feces, lack the dynamic force that characterizes the anxiety of phallic castration. Castration anxiety in the boy of the phallic period can be compared to the fear of being eaten in the oral period, or to the fear of being stripped of bodily content in the anal period. It is the retaliatory fear of the phallic period, representing the climax of the fantastic fears of bodily injury. Ultimately, the idea of castration can be traced back to the ancient biological reflex of autotomy, less profound, but more certainly based on the archaic retaliatory idea of lex talionis, the very organ that sinned must be punished. It is clear that the child's environment reinforces these fantastic ideas of punishment, with many adults still threatening to cut it off when they catch the child masturbating. In general, the threat is less direct, but there are other punishments suggested, seriously or jokingly, and the child interprets them as threats of castration. However, even experiences that objectively contain no threat may be falsely interpreted in this way by a boy with a guilty conscience. For example, the experience that there really are creatures without a penis, the observation of female genitals. At times, such an observation lends serious weight to an earlier threat that had not been given much attention. In other cases, the realization of the phallic phase alone suffices to activate past threats that had not made too intense an impression during pregenital periods. The nature of the danger believed to be threatening the penis also varies. Some believe the penis is threatened by a male enemy, that is, by a penetrating, pointed instrument, or by a female enemy, with an instrument that envelopes it. This depends on whether the father or the mother appears as the most threatening figure, or according to the special fantasies the boy has regarding sexual contact. Boys or individuals with a neurosis involving fear of castration may develop fantasies of the penis flying off the body, microbes devouring the penis, dreams of baldness, cutting hair, extraction or loss of teeth, decapitation. Preventive fear of castration may be represented in a dream as a lizard, which loses its tail and it grows back, or when a penile symbol appears mutilated. There are individuals with oral fixations who fear that their penis will be bitten off, resulting in confused ideas composed of both oral and genital elements. There are men who have an obsessive conscious fear of having too small a penis, the result of some striking observation in childhood of another's penis size, when theirs was truly small. In boys, femininity does not always mean, I think I am already castrated, but rather an evolution toward femininity, which represents a deviation from the active use of the penis, often attempted as reassurance against possible future castration. If I act as if I no longer had a penis, they will not cut it off, or even if there is no way to avoid castration. I prefer to carry it out actively in anticipation of what might happen, and at least I will have the advantage of staying in the good graces of the one who threatens me. The intensity of castration anxiety lies in the intense valuation of the organ during the phallic phase, a valuation that makes the boy decide, when faced with the question, either I renounce my genital functions or I risk my penis, in favor of giving up the function. An adult would ask, what use is an organ when I am forbidden to use it? In the phallic period, however, narcissistic factors counterbalance sexual ones, so that possession of the penis becomes the main objective. Problems of this order result from another characteristic of the oral state. According to Freud, the boy of this age still does not regard possession of a penis as a matter of sexual determination. He differentiates not in terms of man and woman, but in terms of bearer of a penis and castrated. When forced to accept the existence of people without a penis, it is assumed that they once had the organ but lost it. Analysts who have confirmed findings of this kind speculate that this mode of thinking may result from earlier repression. Perhaps the boy has a more primary reason to fear female genitals than the fear of castration, oral anxieties of a toothed vagina, signifying retaliatory fear of sadistic oral impulses. Hence the attempt to deny their existence. I once received an email from a colleague questioning the myth of the toothed vagina, which corroborates what was said above, sadistic oral impulses. Interestingly, he reported that for a year and a half he had been dreaming that all his teeth had fallen out. There was no sensation of pain, and in fact it was even pleasant to feel them loose in his mouth, a dream that may represent castration anxiety. For a precise diagnosis, an analysis would be necessary. The idea that girls once had a penis, but that it was cut off would represent an attempt at such denial. What also comes at the same time is the anxiety. This can happen to me too, with the advantage that the primary existence of the feared female genitals is denied. One does not have the impression that boys console themselves in any way by knowing that certain creatures had their penis cut off. On the contrary, this idea appears very frightening. Moreover, it seems natural that the boy presumes, until he is taught otherwise, that all people are built just as he is, so that this presumption is not necessarily based on fear, but rather that the presumption is incorrect and itself creates the fear. Penis envy in girls. The clitoris in girls is the part of the genital apparatus that presents itself as the richest in sensations and that attracts and discharges all sexual excitement. It is the central point of both masturbatory practices and psychic interest. Secondly, it also means that the girl classifies people into phallic and castrated. That is, the girl typically reacts to the notion that there are creatures with a penis both with the activity, I would like to have this, and with the idea, I already had this but lost it. Women bearing strong penis envy have revealed, through analysis, to have suffered a flight from femininity, developing a certain fear of their own femininity and therefore having constructed a relative envy of the penis. The analysis of obsessive neurotics shows, at first, a quantity of repressed anal and sadistic impulses. Later, it is discovered that, at deeper levels, there exist unconscious genital desires, which were rejected by a regression to sadistic anal desires. Hence, we do not say that the reactive nature of sadistic anal desires contradicts the existence of an original sadistic anal period in the child's libidinal development, but that the reactive desires followed regressive pathways. The girl has the feeling that possession of the penis brings direct erogenous advantages regarding masturbation and urination. The possession of a penis, in the eyes of the girl, makes the possessor more independent and less subject to frustrations, a feeling perhaps resulting from the concentration of all sexual feelings in the clitoris during this phase, the clitoris being inferior in comparison with the penis. Intermediate period. It is the period in which infantile sexuality reaches its culminating point, followed by its decline. Oedipal phase. It is the stage that goes from around the 3rd and 4th year to the 6th and 7th year of life. It is also the most important in the development of personality. It is in this stage that the child develops a great interest in the parent of the opposite sex and, consequently, a strong feeling of rivalry toward the parent of the same sex, with the desire to displace them. During this time, the child learns that their sexual desires are forbidden, presenting feelings of love and hate toward the parent of the same sex. This leads to feelings of anxiety and guilt, as well as fear of punishment for the crime. Freud early discovered in his patients unconscious methodical manifestations of fantasies of incest with the parent of the opposite sex, allied with jealousy and homicidal rage against the parent of the same sex, which he called the Oedipus complex, by analogy with the classical Greek legend of the innocent prince of Thebes, to whom the oracle foretold he would kill his father and marry his mother. Abandoned by his father on a mountainside to die of cold and starvation, he was found and raised by strangers. Upon returning years later, unknowingly, he fulfills the prophecy. Killing the king, he frees the kingdom from the oppression of a wild and terrible creature, then marrying the queen, who was his mother. Out of remorse for the crime, despite the evidence showing he bore no personal responsibility, he tears out his own eyes and, once again, wanders blind and exiled throughout the world. Beyond recognizing that the Oedipal complex is universal, our knowledge of Oedipal desires expanded during the first 2 decades of this century, encompassing what, at first, was known as inverted or negative Oedipal desires, that is, fantasies of incest with the parent of the same sex and homicidal desires against the one of the opposite sex. In turn, this constellation of fantasies and emotions was at first considered exceptional. It was found, on the contrary, to be general. While compiling this research through fragments of books and other works, I decided to cut my hair and that of 2 of my 3 children. The hairdresser complained to me that her daughter was crying when she left for work every day. She thought this attitude strange, since from the age of 3 she had not cried, and now at 7 she was having these crises. She was determined to take her to a psychologist. I explained that I was studying this subject and that she was probably in the Oedipal phase and was seeking an approach to her mother due to some problem with her father. At that moment she revealed to me that she was separated and had no male figure nearby with whom her daughter could relate. That is, in summary, the complete explanation of what we understand as the Oedipal complex. It is a double attitude toward both parents. On the one hand, the desire to eliminate the father jealously hated and even to take his place in a sensual relationship with the mother. On the other hand, the desire to eliminate the mother, also jealously hated, and to take her place with the father. The single most important fact to keep in mind regarding the Oedipal complex is the strength and intensity of the feelings involved. It is a true love affair. For many people it is the most ardent case of their entire lives, but in any case it is as ardent as any other the individual may come to experience. The intensity of the storm of passions of love and hate, ambiguity, of desire and jealousy, of fury and fear that rages within the child. The formation of the superego. The superego generally corresponds to what we commonly call conscience and comprises the moral functions of the personality, which include the approval or disapproval of actions and desires based on righteousness, critical self-observation, self-punishment, the demand for reparation or repentance for having acted wrongly, self-praise or self-esteem as a reward for virtuous or commendable thoughts and actions. There are unconscious desires in every individual, which he consciously repudiates and denies, for there are many moral demands and prohibitions that are numerous and strict within each of us. Therefore, the functions of the superego operate in the unconscious. The intensity of the fear of castration becomes so strong and unbearable that the child is forced to surrender before a very powerful rival and to give up their desires toward the parent of the opposite sex, thereby repressing their sexual feelings. By renouncing the aggressive feelings toward the parent of the same sex and the sexual feelings toward the opposite sex, the child identifies with parts of each parent, making them parts of themselves, parts that will form the child's superego. With the superego, it is understood as what the child internalizes, taking from each parent what is classified as a moral value and as an ideal. One portion of the superego is the part that establishes what is right and wrong. The other part, called the ego ideal, is composed of the elevated characteristics that all must bear in order to become worthy of praise and general approval. The superego is primarily an unconscious part of the psyche. The moral demands and prohibitions of parents, nurses, governesses, and teachers, who can act as parental substitutes, begin very early to influence the child's mental life. Their influence certainly becomes evident by the end of the first year of life. The moral demands of this earliest period are quite simple if judged by our adult standards. Among the most important are those related to hygiene habits. Ferenczi referred to these precursors of the superego as sphincter morality. In the pre-Oedipal phase, however, the child treats the moral demands placed upon them as part of their environment. If the mother, or some moral authority, is present and the child wishes to please her, they will avoid transgression. If alone or angry with the mother, the child may displease her or act as they please, being only dominated by fear of punishment. During the Oedipal phase itself, things begin to change in this regard, and around the age of 5 or 6, morality becomes an intimate matter. It is then that the child begins to feel for the first time that moral standards and the demand that wrongdoing must be punished, arouse repentance, and be corrected come from within themselves and not from another person they must obey. By the age of 9 or 10, this process of internalization becomes stable enough to be absolutely permanent, even if, in normal circumstances, it is still subject to expansion and modification throughout adolescence and, perhaps, to some extent in adulthood. As the child abandons and represses, or in any way repudiates, the incestuous and homicidal desires that constitute the Oedipal complex, the child's relationships with the objects of those desires are largely transformed into identifications with them. Instead of loving and hating the parents who, the child believes, oppose those desires and punish them, the child becomes like them in the repudiation of their desires. Thus, the original nucleus of the superego's prohibitions is constituted by the demand that the individual repudiate the incestuous and hostile desires that compose their Oedipal complex. Moreover, this demand persists throughout life, unconsciously of course, as the essence of the superego. The superego originally consists of the internalized images of the moral aspects of the parents in the phallic or Oedipal phase. The ego is able to partake of the parents' power by identifying with them, but at the cost of a more or less permanent submission to them. Freud made 2 further observations concerning the formation of these identifications. The first is that the child endures the parent's prohibitions largely as orders or verbal admonitions. The second observation was that, to a large extent, the images of the parents introject to form the superego are those of the parents' own superegos. Parents, in raising their children, tend to discipline them just as they were disciplined by their own parents in childhood. Their particular moral demands, acquired in their childhood, they now apply to their children, whose superegos, consequently, reflect or resemble the superegos of the parents. This characteristic has an important social consequence, as Freud pointed out. It leads to the perpetuation of a society's moral code and is, in part, responsible for the conservatism and reluctance to change shown by social structures. Instinctual cathexes are withdrawn from their original objects, and their constant search for another object leads to the formation of an identification with the original object within the ego itself, to which the cathexes then become attached. Thus, what was object cathexis becomes narcissistic cathexis. In the case that now concerns us, naturally, the identifications thus formed within the ego comprise the determined part of the ego that we call the superego. Thus, from the point of view of the ID, the superego is the substitute and heir of the Oedipal-object relations. It is for this reason that Freud described it as having its deep roots in the ID. The incestuous or homicidal impulses of the child toward the parents are repressed and continue to live in the ID as repressed desires, still directed toward the original objects, but prevented from openly expressing themselves in acts or in conscious thoughts and fantasies. However, these repressed Oedipal desires, with their cathexes, do not contribute to the formation of the superego. The intensity of the child's own hostile impulses toward the parents during the Oedipal phase is one of the main factors in determining the severity of the superego, and not the degree of hostility or severity of the parents toward the child. This can be explained as follows. When the Oedipal objects are abandoned and replaced by superego identifications, the energy of the impulse that previously cathected those objects remains, at least in part, at the disposal of the portion of the ego newly established, which we call the superego. Thus, the aggressive energy available to the superego derives from the aggressive energy of the Oedipal object cathexes, and the two are at least proportional, if not equal in quantity. That is, the greater the amount of aggressive energy of the Oedipal object cathexes, the greater the amount of that same energy that will subsequently be at the disposal of the superego. As a consequence, the small child whose Oedipal fantasies were violent and destructive will tend to feel a greater sense of guilt than others whose fantasies were less destructive. One way of formulating the conflicts of the Oedipal period is to state that the ID impulses associated with the objects of that period, namely the parents, lead the child to believe that they are exposing him or her to the danger of bodily injury. In the case of the boy, the fear will be of losing the penis. In the case of the girl, it will be something analogous to the fear of genital injury or an intensely unpleasant feeling of mortification due to the lack of a penis, or both. In any case, there is on the one hand a conflict between the demands of object cathexes, and on the other, those of self-cathexes or narcissistic cathexes. Illustratively, the problem is resolved in favor of the narcissistic cathexes. The dangerous object cathexes are repressed or abandoned, or are mastered or repudiated by other means, while the narcissistic cathexes remain essentially intact. The narcissistic component of the child's instinctual life is normally stronger than the part that refers to object relations, although the latter are much easier to observe and consequently more likely to occupy our attention. In the formation of the superego, modifications, additions, and alterations are established that result from an identification with an object in the child's or adult's environment, with the moral aspect of that object. These identifications are especially common in prepuberty and adolescence, and shape the individual's superego, aiming at the acceptance of the moral standards and ideals of the social groups to which the individual belongs. Modifications to the superego may even occur during adult life, as happens, for example, as a consequence of religious conversion. Nevertheless, the original nucleus of the superego formed during the Oedipal phase will always remain the firmest and most effective part. Consequently, the prohibitions against incest and parricide are the parts of morality most completely internalized by most people, or conversely, the least likely to be transgressed. Other prohibitions of the superego are more subject to transgression, provided there is a particularly favorable opportunity or an especially strong temptation. The superego arises as a consequence of the introjection of paternal prohibitions and exhortations in the Oedipal phase, and for the rest of life, its unconscious essence continues to be the prohibition of the sexual and aggressive desires of the Oedipal complex, despite the numerous additions and alterations it later undergoes in childhood, adolescence, and even in adulthood. The resolution of the Oedipal conflict. Both in the resolution of the Oedipal conflict and in the formation of the superego, in the boy, it occurs as if, there is no way I can have my mother only for myself, but I can make a part of her, her ideals, inclinations, criteria of judgment, become part of me. Thus, I will possess her in a safe way. As for my father, whom I love and hate, and therefore fear, I cannot rid myself of him, but so that he will no longer castrate me, I will become like him, adopting part of his moral principles and values. And then he will like me and no longer be dangerous to me. In girls, the attraction to the father is also called Oedipal by us Freudians. Jungians call it the Electra complex. The resolution of the situation is much more complex for the girl than for the boy. For the latter, despite having to give up his attachment to his mother, normally, when mature, enters into a bond with a substitute mother, the wife. The girl, however, who begins attached to her mother, becomes attracted to her father in the Oedipal phase, hates the mother, wants to have the father all to herself, but eventually gives up, compensating with the purpose of one day having a man of her own. But what happens is that a healthy woman is not able, like a man, to find a substitution for the infantile attachment, and is thus led to compensate by proposing to have a child herself, to become a mother, and thereby realize a satisfactory mother-child relationship. If the Oedipal conflict is not satisfactorily resolved, what can occur? Excessive identification with the parent of the opposite sex may be associated with the development of characteristics of sexual inversion in boys and even in girls. Fear of the parent of the opposite sex may impair the individual's ability to relate to people of that sex later in life. A partially resolved Oedipal stage may result in a poorly formed or even deficient superego, which may in turn determine sociopathic alterations of character and neuroses. Causes of an unsatisfactory resolution of the Oedipal stage. Entry into the Oedipal period with conflicts from the oral, anal, or phallic phase, which belong to the pre-Oedipal period, thus bringing into a new period someone without sufficient energy to face the new circumstances. The absence of one of the parents, without there being an adequate substitute, due to divorce or any other kind of separation. Severe psychopathology on the part of one of the parents, for instance, one who is excessively seductive, cruel, threatening, rejecting, inconsistent, insecure, constantly shifting, cold, etc. Severe defects in the superego, such as an effeminate father, may determine a confused identification with such a parent, which may result in an unstable, inconsistent, and unreasonable superego formation. At the end of the Oedipal period, the principle of what Freud called the genital phase is established, in which the primary interest becomes genital experience, that is, the tendency to unite the genital organs with the opposite sex. It is attraction directed toward another person, an object redirection, which signifies surpassing the autoerotic phase, as it was until then in the last phase, the phallic. Latency phase. This is the phase from ages 6 to 14, or until puberty. The characteristic of this phase is the repression of fantasies and sexual activities, in which desires and impulses are repressed into the unconscious. Mothers often report that from the age of 7, children, especially boys, become more docile. In reality, what occurs is that children enter a period of sexual quiescence. Here psychic forces arise, which will later appear as obstacles to sexual drive, narrowing its course like a dam: disgust, the feeling of shame, the demands of aesthetic and moral ideals. Although education has much to do with the construction of these dams, such development is organically conditioned and fixed by heredity, and may occur at the appropriate moment independently of educational assistance. Education remains entirely within its proper scope when it limits itself to following what has been organically predetermined and imprinting it in a somewhat more refined and profound way. In Freud's original classical description, sexual manifestations are quiescent in this period. In particular, there is a deep repression of masturbation, which remains the great temptation and problem of the age. It was concern with masturbation and other direct libidinal manifestations that led early analysts to neglect this period, though an additional factor was the virtual absence of children as patients. The latency period provides the child with the equipment, in terms of ego development, to prepare for the encounter with the increased impulses of puberty. Consequently, the child is able to divert instinctual energy into differentiated psychic structures and psychosocial activities, rather than experiencing it solely as an increase in sexual and aggressive tension, which we may call sublimation. The first part of latency begins at about 7 to 8 years. It is characterized, according to Freud's observations, by the passing of the Oedipus complex and the formation of the superego. Here there is a first love case with a child of the same or close age. It is quite intense while it lasts, then abandoned after a rather short interval. The consolidation of the superego and the strengthening of ego mechanisms continue to be primary concerns. The second part of latency runs from ages 8 to 14. It is characterized by the search for peers and the formation of groups, both for boys and girls, and by considerable endocrinological changes. Psychosexual maturation phase, or puberty. This period extends from ages 12/15 to 18. It begins suddenly, with an intense endocrinological activity in the organism, which results in an exacerbation of the libido. From this point, the individual rapidly resumes the stages of sexual development, having just emerged from the quiescence that characterizes the latency period, which, in reality, was only an interruption of the intense sexual development experienced during the pre-Oedipal and Oedipal stages. In this phase, there is a tendency for a readdition of oral, anal, and phallic impulses, and a mixture of sexual interest and conflict with the parents, as in the Oedipal stage. From the sexual point of view, it is the most important period in human life. Between birth and death, it is precisely at this stage that sexual maturation occurs, marked by the first elimination of germ cells, the first nocturnal emission among boys, and the first ovulation associated with menarche among girls. This occurs exactly in puberty. Puberty is a physiological, psychic, and sexual revolution that unfolds from within the organism outward. What suddenly appears as psychological sexuality is nothing more than the external manifestation of heightened glandular activity in the innermost recesses of the being. The same sex hormones that form sexual type guide the body, the soul, and sex from the infantile state to maturity, and from there to old age, carrying out the slow evolution and involution of the organism. Puberty is characterized by certain general physiological effects: rapid body growth and strengthening of the skeleton, the appearance of hair in the armpits and pubic region, and more broadly, modifications of physiology and habits. During puberty, The growth of girls occurs more rapidly than that of boys, unlike what is observed in the preceding and subsequent periods. Girls at 15 years of age are, in general, taller and heavier than boys of the same age. In compensation, their growth ceases around age 20, while in boys it continues until about age 23. Parallel to the development of sexual characteristics, provoked by physical constitution, sexual instinct, and psychic pathways, psychophysical personality undergoes very important modifications during puberty. Self-consciousness, heightened or exaggerated, contrasts strangely with diminished physical resistance. The general modifications due to puberty make up that indefinable set which constitutes beauty, that is, feminine aesthetics. At birth, everything is disproportion and ugliness. The head is enormous and disproportionate compared to the rest of the body, and growth gradually seeks harmony, establishing human physical proportions. The skin of women in puberty is delicate. At the time of menstruation, it may present a slightly bluish coloration, especially in brunettes, more noticeable around the eyes, where it forms a dark ring. A few months before the first menstruation, the pubis is covered with hair, the color of which may differ from that of the scalp hair. After the pubis, the armpits are also covered with hair. In most cases, menstruation has already begun when the hair system in these regions manifests. All the skin glands, sebaceous, sweat, etc., develop at the onset of puberty, producing sebaceous secretions and the genital odor. We know the role this odor plays in animals, provoking the attraction of the sexes, that is, sexual pleasure. The age at which the child transforms into an adolescent varies according to latitude. Here one must admit the influence of the sun upon the sexual process. In polar regions, puberty does not manifest before 18 years of age. During the polar night, which lasts 6 months, women in Lapland and Greenland do not menstruate. In the hot regions of Africa, however, puberty often begins between ages 8 and 10. Not only climatic conditions, but also the particular conditions of life and diet, as well as social environment, absorbed information, may precipitate or delay puberty. The first nocturnal emissions and menstruations generally manifest between ages 12 and 14. However, the range is wide for both sexes, and thus the first elimination of germ cells at 17 should not be considered pathological. Phenomena of puberty before the age of 10 can be called precocious, while those that begin after age 18 can be considered delayed. Pollution, involuntary emission of sperm. Sperm is an opaline grayish, semi-transparent liquid that contains the product of the seminal glands, that is, the spermatozoon. The composition of this alkaloid consists of albuminoid matter, which does not contain the relations of albumin nor fibrin, but of spermatin. This is soluble in water without being coagulated by heat. Dried sperm, when in contact with water, swells again. This process is used for medical legal recognition of stains found on sheets, since by this process it is possible to carry out, in the liquid obtained, the examination of spermatozoa, the only means of clarifying its nature. By cooling, small prism-shaped crystals can be found in the sperm, successively formed by crystals of magnesium phosphate, calcium phosphate, and albumin. Menstruation or menses. It is the blood that women lose starting from puberty, which occurs every lunar month, every 28 days, with greater or lesser abundance, possibly extending to 30 days. Among the ancient Hebrews, women were, by law, considered impure during the menstrual period, and everything they touched was also considered impure. Thus, they were practically isolated from the group for a period of 7 days, returning to normal life after a purification ritual. Due to these practices, even today there are people who act similarly, where sexual intercourse is prohibited. On the other hand, many women are aroused by the smell of blood, finding intercourse during this period very pleasurable. Others feel more at ease in the act, as the risk of unwanted pregnancy is eliminated at this time. Currently, most women go through their menstrual cycles almost imperceptibly, carrying out their activities normally. Only a small portion, due to dysmenorrhea, mastodynia, or menstrual cramps, are unable to perform their daily tasks. However, around the 14th day of the menstrual cycle, counted from the beginning of menstruation, it is impossible for it to go unnoticed. It is the moment when the woman is at her maximum hormonal load and sexual desire is in the air, feeling an intense desire to make love, and most of the time, not knowing how to communicate this to her partner. Then she feels irritated, bad-tempered, without knowing the cause. In the absence of a steady partner, it is common for the young adolescent to engage sexually with a friend or acquaintance. It is during this period that the young girl, even wishing to remain a virgin, may lose her virginity. It is also here that unwanted pregnancy often occurs. Final adolescence phase and the young adult. In this period, from ages 16-18, and for the rest of life, the so-called fixation points can be observed. These correspond to unresolved, or at least not satisfactorily resolved phases, which determine the existence of an adult individual who exhibits immaturity in certain areas of character, sexual identification, emotional balance, tendencies to regress under stress, inability to form a stable relationship, sexual choices, and evident indications of the outbreak of neurotic behavior. Sexuality in old age. The process of aging is irreversible and continuous, its symptoms being both development and decline. These processes are interconnected throughout life, given that new cells are constantly being formed while others are destroyed. Some are of short duration, such as those forming the outer layers of the epidermis. Since aging is a reality, the important thing is to prepare for aging with quality, that is, with mental, physical, and emotional health, and consequently a healthy sexual life. As for sexuality, what we most observe is a psychological unpreparedness, influenced by culture, full of taboos. If in adolescence we already have many prejudices, imagine in so-called old age. It is not accepted to see an elderly person dating, and in most cases, the elderly themselves do not accept such an idea. How many are there who, even at 40 years of age, already say, "I am too old for this"? Which is absurd, since it has been proven that the human being, man or woman, can have an active sexual life until the end of their days.